Good morning, everybody. So welcome. Welcome, everyone, to the Canadian Council of the Blind 2026 Vision Health Month Conference. Woo! Yes. Our title this year is Pan-Canadian Voices, a national conversation on the future of eye care in Canada. My name is Leslie Yee, and I'm the first Vice President of Canadian Council of the Blind, and I am very honored and I feel very privileged to be able to be your MC for the day. This morning, to start us off, I'd like to thank our sponsors. They are AbbVie, AMI, Astellas, Bausch & Lomb, Bayer, Johnson & Johnson, Roche, and Specsavers. It's because of your support that we can be gathered here today, so thank you. For the land acknowledgement, we are gathered here today in Ottawa. We acknowledge that Ottawa is built on the unceded and unsurrendered territory of the Anishinaabe Algonquin people. We honor their stewardship of this land since time immemorial and recognize their ongoing contributions to this region. As we all gather here today, we commit to working together in spirit of openness and warmth, sharing ideas, fostering understanding, and building relationships rooted in respect and collaboration. So I would like to now invite Jim Tokus to the stage to give us a welcome.
Thank you, Leslie. Probably too loud. That's okay. I'll stand back a bit. So, anyway, on behalf of the Canadian Council of the Blind, welcome to everyone who's here in person, and also welcome to everyone who is joining us virtually. We hope you enjoy today's proceedings, and if there's anything anybody needs, as Leslie says, please put your hands up, and we have people that will be more than willing to help you out. So enjoy yourselves. Thank you for being here, and we'll talk to you as the day goes on. Thank you.
Thank you, Jim. So good morning, everyone, and welcome to the Canadian Council of the Blind 2026 conference. It is truly wonderful to have you join us as we gather today from across the country to explore this year's theme, Pan-Canadian Voices, a national conversation on the future of eye care in Canada. As Canada moves forward with the National Strategy for Eye Care Act, we are reminded that access to vision care is far from uniform. Geography, language, funding models, workforce shortages, and the unique needs of local communities all shape how and whether people receive the eye care they need. Today is about bringing those realities into one shared space and hearing directly from the people who live, work, and lead within them. This conference brings together an incredible mix of perspectives: optometrists and ophthalmologists, policy leaders, rehabilitation professionals, researchers, and individuals with lived experience of sight loss. By centering regional voices, we're challenging the idea that one model can serve everyone, and instead exploring what equitable, community-rooted vision health can look like from coast to coast to coast. We're fortunate to have several inspiring speakers with us this morning. You'll hear from researchers like Angelica Hanna, who is examining how socioeconomic factors shape access to care across Canada. Leaders such as Dr. Alison Scott, President of the Canadian Association of Optometrists. She will help us understand both national trends and the realities of delivering care in regions like the East Coast. and advocates like Jennifer Urosovic speaking on behalf of Vision Health Partners Coalition, who will share important updates on the national strategy for eye care and the work underway to advance it. We'll also hear powerful stories from those working directly in communities, including Dr. Sabri, whose work with the Indigenous Children Eye Examination Project brings pediatric care to Northern and Indigenous regions, as well as accessibility leaders like Catherine Langlois from Via Rail, who will highlight how inclusive travel is being planned for Canada. After lunch, we will host a panel on rehabilitation and services, where professionals from across the country will reflect on how equity challenges show up in their day-to-day lives and what solutions are emerging on the ground. So together, these voices remind us why this conversation matters. Vision health is not just a clinical issue, it's a social one, a community one, and a national one. And today we have the opportunity to learn from each other, challenge assumptions, and imagine a future where every person in Canada has access to the eye care they deserve. Thank you, everyone, for being here, for lending your voice, and for helping shape the future of vision health in Canada. So let's begin. Our first speaker is Angelica Hanna. Angelica is a medical student at the University of Toronto who recently completed a Master's of Science in Health Systems Leadership and Innovation at the University of Toronto. Her work focuses on equity in vision care and access to eye care services in Canada, with research exploring how socioeconomic factors influence vision health, healthcare utilization, and barriers to eye care. She has published work examining disparities in vision care access and outcomes across Canadian populations. Alongside her research, she is actively involved in community outreach initiatives serving marginalized, rural, and First Nations communities through organizations including IVAN, Kids to See, and the KEI 4C Canada Marginalized Vision Clinic. She's passionate about combining evidence-based policy, advocacy, and patient-centered care to improve equitable access to vision services across Canada. So let's give a big welcome to Angelica.
Good morning, everyone. Thank you for the kind introduction. My name is Angelica. I'm a third-year medical student at U of T, and it is truly my honor to be with you here today. Today, I'm going to be talking about some of our work looking at sociodemographic factors and eye care uptake across Canada. I have no disclosures. All right, I want to go through a few different patients that I've seen in clinic, loosely based on a few different patients that I've had the privilege of working with. Let's start with Barb. Barb is 68 years old. She lives in Geraldton, Ontario, very northern Ontario. The closest ophthalmologist to her is about 4 hours away. She lives alone, and she's been noticing some worsening in her vision, but she's kind of been delaying her care. It's 4 hours away to go see an ophthalmologist. She's just been living with it. Next, we have Nadia. She's a 42-year-old single mom who lives right in downtown Toronto. She has diabetes, and she needs her yearly diabetic retinopathy screening. But she works an hourly job with no sick leave, and so she keeps missing her diabetic eye screening appointments because she can't take time off work. Okay, next we have Jaden. Jaden's a 6-year-old who also lives in Toronto. He lives in the inner city, and he's struggling in school because he can't see the board. He's never had a comprehensive eye exam, and he goes on as is. Lastly, we have Maria. Maria is an 81-year-old recent immigrant to Canada. She lives in Hamilton, and she speaks limited English. She doesn't understand why routine eye exams matter, and she's noticed some decreases in her vision, but she thinks that normal vision declines as we age. So despite the universal healthcare system, we know that barriers persist in accessing eye care. All 4 patients live in Ontario, and all 4 patients have access to services that they need. However, none of these patients are able to actually access the care and use it. Earlier care can improve the outcomes for all of our patients here, but there are barriers that persist. We have geographic barriers, financial barriers, social and language barriers, as well as health literacy barriers. And so what we're really getting at here are the social determinants of health. Now, social determinants of health are non-medical factors that influence our health and influence our vision. These include social, economic, and environmental factors. These aren't our genetics, these aren't the diagnoses that we have, but it's everything else around that that influences our actual health outcomes. And here are a few of the social determinants of health that I'd like to talk about. First, we have the health care and quality. So there's insurance coverage, health literacy, factors around co-pays, provider availability, and the quality of care that we receive. But beyond that, there's the neighborhoods we live in, the housing that's around us, the transportation, the safety of our neighborhood, the weather, water quality, access to healthy food. All of these things influence our health and ultimately our vision. Social and community contexts, stress, racism, discrimination, all of these things influence the way that we're able to seek care and our health overall. Finally, economic stability, employment, income, debt, education, and access to information are all factors that influence our health. Well, what about social determinants of health in ophthalmology? There's been plenty of evidence in the medical literature for non-ophthalmology conditions that the social determinants of health influence our health outcomes. But how about for our vision? What is the role of income in vision care utilization? I'd like to credit some of my co-authors here as I'm about to share some of the work that we've been able to do examining this very question. We have Dr. Diana Martinez, Dr. Ike Ahmed, and Dr. Matt Schlenker, who've all been integral in this work that we've done. And really what we did was conduct a systematic review to overall look at the totality of the evidence in Canada. How does socioeconomic status impact our vision care utilization? So we did a systematic review looking at all of the literature that's been published. And looking at studies between 1985 and 2022, we had 23 Canadian studies with over 18 million patients implicated. And we looked at the evidence and we found that overall, lower socioeconomic status was associated with decreased vision care utilization. And this was consistent across provinces, across age groups, and for all care types: optometry, ophthalmology, and screening healthcare. And the utilization disparity was prevalent across the spectrum of eye care. This included general visits, so general screening by optometrists and ophthalmologists. We have preventative care with diabetic retinopathy screening, as well as specialist care with tertiary care utilization, as well as no-shows and cancellations were also found to be higher among patients with lower socioeconomic status. And now the magnitude of the disparity was quite large. In terms of general eye care utilization, about 42% of the higher income population is using eye care, but only 28% of the lower income population did. In terms of homeless and marginally housed populations, this disparity is even greater. 15 to 18% of patients who are homeless and underhoused used eye care services, while 41% of the general population did. This even stretches into pediatrics. High-income children were 80% more likely to have a routine eye exam than children in the lowest income quartile. Another interesting factor that we explored was the delisting of eye care in 2004. So in 2004, the Government of Ontario delisted routine yearly eye exams for patients who were not seniors and not children. This allowed a natural history study to go underway. What happens to the use of routine eye care when it's not covered? And we found that after the delisting of eye care services, the gap increased. Instead of a 5% gap between the rich and the poor, it increased to 12%. So our studies show that funding does influence eye care, but disparities do persist in spite of funding. Now, lower socioeconomic status patients had decreased utilization of eye care services even when services were covered. This persisted amongst the seniors and in the diabetic retinopathy screening population, with lower income patients being 40% less likely to undergo screening compared to their higher income counterparts. We found that 5 out of 6 studies examining diabetic retinopathy found that patients with diabetic retinopathy were less likely to undergo screening if they were in the lowest income quartiles. And there are multiple mechanisms that can be driving this, and we've spoken about some of these in terms of social determinants of health. There is the lack of insurance and out-of-pocket costs, although we do know that this persists when those are eliminated, but there are system-level barriers. The availability of services, the fragmentation of optometry and ophthalmology services. There's also logistical constraints, transportation, time off work, weather, childcare responsibilities, social and behavior factors like health literacy, perceived need, and trust in healthcare. So I think I've convincingly showed you that the evidence shows that patients of lower socioeconomic status are less likely to use eye care. But how does that actually translate into their vision? Does decreased utilization ultimately mean lower outcomes? Well, we did another review to look at this, and we summed up the totality of the evidence in Canada, and we looked at 28 studies across the country. And we found that 11 out of 14 studies showed that patients with decreased socioeconomic status, lower income, were more likely to have visual impairment, and they were also more likely to have ocular diseases. And this was consistent across provinces. We found that lower income patients were 2 times more likely to experience visual impairment, and in the higher socioeconomic status group, 23% had visual impairment, whereas 54% in the lower socioeconomic status group had visual impairments. This also was shown amongst the educated versus those with lower education. Those with a higher education had 31% of whom had visual impairments, as opposed to 47% who did not have a higher level education. This also persisted into certain diseases. Patients with lower socioeconomic status were more likely to present with late-stage glaucoma. They were more likely to present with more severe cataracts and have a more advanced presentation of cataracts. They were also more likely to present with early onset cataracts. Macular disease was also more common amongst our lower socioeconomic status patients, and neurological diseases, including idiopathic intracranial hypertension, was more common amongst patients who had lower socioeconomic status. So overall, lower income and more sociodemographic barriers lead to less vision care utilization and worse vision. Well, everything so far has been doom and gloom today. Let me give you some hope. What is being done around the country to mitigate these barriers, and what's been going on? I'd like to highlight some of the work that I've been privileged to see by the CNIB and VLRC with the iVan. For those of you who aren't familiar, the iVan is a very large truck, as you can see here, that drives around Northern Ontario, providing eye care to towns across the country. There are many patients who do not have good access to ophthalmology services up there, and so ophthalmologists from larger cities in Southern Ontario each spend a week up on the iVan, providing eye care services to patients up north. As you can see here, in that very big truck that you saw, we have a full clinic. We have a slit lamp, we have lasers, we have the capacity to do small procedures. All of these things that you would find in a clinic right here in downtown Ottawa, you can find up on this truck that spends time going around Northern Ontario. Another group that I'd like to highlight is 4C Canada. This is quite the opposite. We're working in downtown Toronto, downtown Hamilton, looking at working with patients who are socially disadvantaged, who, although they live in the big city and there are many optometrists and many ophthalmologists who should be easily accessible to them, due to a variety of factors, they're not able to access eye care. So instead, we partner with community organizations, community centers, groups that understand the community, and we provide screening right in the community centers, allowing patients to get some semblance of eye care, just a screening of eye care. And if higher needs are identified, they're able to be absorbed into the practices of the physicians who are providing this screening. I'd also like to highlight the work of Dr. Myrna Lichter. She's been a leader in homeless care and care for the marginalized in downtown Toronto and downtown Hamilton. She runs a practice where we have a portable eye clinic. We have a portable slit lamp, we have portable visual fields, and a portable indirect ophthalmoscope, and we can go to patients, go to the shelters, and screen patients who are experiencing homelessness and those who are underhoused. In this way, they can get a little bit of eye care, and again, if any needs are identified, they can be absorbed into her practice and absorbed into the practices of physicians in the area, but it's just a start to get them some level of eye care. Finally, I'd also like to highlight the work of Dr. Ashwin Malapatna with Kids to See. So Kids to See also works in inner city Toronto, going into schools that are in lower income neighborhoods, providing basic vision screening to all JK and SK children. Any kids who are flagged on these exams are brought into Sick Kids for a full evaluation, but for some families where it may be hard to bring in their kids for a routine eye exam, this is a safety net that allows some level of eye care. Now, as much as I really like all of these different organizations that I've just talked about, I wish none of them existed. I wish we didn't need to have a special program to outreach these children. I wish we didn't need to have a special program for the homeless and for those who live in Northern Ontario. Ideally, our health system would already capture those. And it's for that reason that I'm very passionate about research and health systems. So the main theme of our work with the health systems is collaborating with patients to change the status quo. We're trying to understand barriers to care from the patient perspective and address these systemic barriers so that we can change and prevent inequities. In cataract care, some of the work that we've been looking at and working towards a grant with the CAHR for is looking at patient experience with cataracts and doing patient interviews to work with patients who present with very advanced cataracts. Why do patients present with very severe vision loss when cataract surgery is publicly funded? We also want to investigate how socioeconomic status, geography, sex, and gender all influence our access to surgery. And we also want to study how patient-reported outcome measures should be used to prioritize and triage equitable surgical prioritization. In glaucoma care, we're also working to study patient perspectives and treatment experiences using qualitative interviews and patient-reported outcome measures. We're also developing patient-centered glaucoma surgery referral and prioritization tools and investigating barriers to timely diagnosis and surgical care across Canada, and overall exploring racial, socioeconomic, geographic, and other inequities in glaucoma outcomes. So I wanted to thank you all for having me today, and I welcome your questions. We're always looking for patient collaborators, and I really welcome your thoughts. Thank you.
We do have a mic. If anybody has any questions, just put your hand up and we'll bring a mic over to you.
Oh, yes.
Henna, that was really compelling research. I appreciated how you broke it down and you asked questions along the way to keep us engaged. So well done on that. But I really appreciated the data that you provided. My question is, where do you take this research to see change affected so that people in the vision loss community see the benefit of the work you're doing? How do you take it from lab and report to reality?
Absolutely, and that's the big question, because we can do as much research as we want, and that can stay within our medical communities, but if that doesn't reach government work, things won't be able to change. And that's where I see advocacy from the Canadian Ophthalmology Society, the Canadian Association of Optometrists, the work done here by the Canadian Council of the Blind being into play. If we can show policymakers that this is something we care about, this is something that influences Canadians, and this is something that we see changing the quality of life of people, I think that's where we can see growth. So yes, we can do research as much as we want. I can sit and do all the systematic reviews in the world, but that's not going to change anything. If patients like yourselves here don't make it to policymakers, your influential stories don't make it to policymakers, and we can convince people that these are not just data, these are actual people whose vision is being impacted and whose quality of life is being altered. Yeah.
That was really interesting research. I was taking tons of notes and pictures. My question was if you've seen effective examples of campaigns to work on those attitudinal kind of barriers. The example you shared of the older woman in Hamilton who assumed that sight loss is just something that happens because you're older. I found that so, that gets to the heart of it. And if, a lot of the examples were focused on, getting services to people but, the other movement would make it easier too, to not change a whole system and just, have people know that this stuff is important and kind of access to services are already right there. Have you seen things that are really effective, or do you think we need to be doing more work that way too?
Yeah, you highlight a very important point there. If patients and health literacy doesn't improve, then our work is really futile. I've personally not been involved in any work like that, but the closest thing that I can think of is our work with 4C Canada is working with communities and working with community health networks where the social workers and the people involved in those communities really understand the demographic, they understand the patients. So working on a grassroots level where there's already lots of connection with the communities, educating those patients who may have the lowest level of health literacy can be a start. Besides that, other campaigns, in other fields of medicine, they've been very excellent at this. Think of mammogram screening in Ontario. I think most people understand very well at age 40, you can just sign up and go get your mammogram. I think that campaigns similar to that in ophthalmology and optometry, advocating for vision health and educating patients about what is and what is not normal for their vision could be a really helpful next step for improving health literacy and for patients understanding what's normal and what's not.
Hi, it's Diane Bergeron from CNIB. The information was fascinating. I'm wondering if you've done in the research, when you're looking at the programs that are providing the services, especially in the area of children, but any of those programs that are providing services, have you done any kind of ROI, any kind of research on, given this service to this group of individuals, what is the cost savings in providing those services to help the advocates go to government and say, this program is saving you money in the healthcare system?
Yeah, you highlight a very important point there, proving to policymakers that the financial investment of doing these screenings, providing this care, outweighs the negative consequences of patients having decreased vision. I actually have not seen much work on that, and that would be a very interesting next step. Doing the case costing and showing that would be very interesting. But no, I've actually not encountered any research on that as far as I'm aware right now. That's a good next step.
Hi, Angelica. We have a question online here from Sarah Shepard. And the question is, have you had the opportunity to present this to any government yet?
I have not. I know that there's a lot of work being done in terms of advocacy from the Ophthalmology Society, the Optometry Society. I think that showing work like this could be quite helpful, knowing that there is a very large sum of evidence that shows that there are disparities. But from my perspective, no, but I'm sure that there are people hard at work outside of here who are showing this work elsewhere.
I have one more question online here from a Sue Marsh Woods. They were wondering if you could provide a copy of your presentation. This person is part of VLRC, and they did some work with Dr. L, and they would love to be involved with you as well. So just wondering if you're open to sharing that.
Very open to collaboration, absolutely.
I just want to see if there's any questions in the room. I do have some more online questions here. Okay, another question here from a fireman. It says, what is the role of family doctors in this research?
That's a great question. And I think that what some of the evidence showed is in 2004, when the delisting of routine eye exams was done, there was an increased burden on family doctors. Now, if you go to any conference in Canada about family medicine, you will know that there is already a very high burden on family physicians. Now, that's not to say that vision care is not something that they should be taking care of, but if we're only to rely on family doctors for screening and for vision health, I think that we are doing a disservice to our patients. Family doctors are so overwhelmed with so many other things that they must take care of, and if we can have some family doctors involved and do some level of screening and some level of advocacy, that would be wonderful. But I think we need to use as many different avenues as we can to outreach our patients. If family doctors are one of them, so be it, but we need as many avenues as we can.
any other questions in the room? Okay, that's great. Thank you, Angelica.
Thank you very much. That was a lot of really good data to know and to have. I'm also interested in seeing that report too. So our next speaker is Dr. Alison Scott. Dr. Scott is president of the Canadian Association of Optometrists. Dr. Scott graduated from the University of Waterloo in 2006. She has been practicing in the Halifax area since graduation and enjoys working in a family practice, sometimes seeing multiple family generations. She has recently started a specialty contact lens practice. Dr. Scott has been on the NSAO Council since 2011 and has served many roles, including president. Dr. Scott has served on their public education and continuing education committees. She is also an official with Skate Canada and enjoys volunteering at local events in the capacity of figure skating judge. Welcome, Dr. Scott.
Thank you. Hi, everyone. Thank you, Leslie, for your kind introduction. And as Leslie mentioned, I'm Dr. Alison Scott. I'm an optometrist and also the president of the Canadian Association of Optometrists. And interesting, Leslie mentioned my work as a Skate Canada official, and actually Skate Canada is working on a visually impaired classification for para skating as well, and I get to be part of that committee, which is really interesting, and I look forward to see hopefully that sport grow as well. But I'm really pleased to be here as my capacity as president of the CAO for the Canadian Council of the Blind's Vision Health Month conference. I think this theme, Pan-Canadian Voices, is really fitting, especially as we are waiting for the tabling of our national eye care strategy. So many of us here today have experienced the firsthand barriers to equitable eye care in Canada. Whether you're a patient, a caregiver who has been helping someone navigate our systems, or as a healthcare provider, just trying to do the best and provide the best care to our patients to give them the best outcomes. But really, like, the reality is that eye care is not just eye care. It's part of a broader healthcare system that is really important. But that system's under enormous strain. It has really often falls hardest on the people who can least afford the care, and often compounds with those who are already impacted by the issues that they're experiencing. So too many Canadians don't have a family doctor. I certainly see that on the East Coast, and unfortunately I think I'm going to be one of those people in the next month as my family doctor is leaving the province. Specialist wait times are getting longer and longer. Emergency departments are overwhelmed. And I don't think that's any news to any of us that are here. But people with vision loss and chronic eye conditions and chronic conditions, those pressures just they don't just add up, they multiply. So across the country, there's been growing recognition that one way to ease the strain is to make better use of our regulated health professionals who have extensive training but aren't always permitted to work to their fullest capacity. And we've seen scope expansions for pharmacists, physiotherapists, and nurse practitioners in recent years, precisely because that's what the system needs. So optometrists are very much a part of that conversation. And increasingly, optometrists are playing a role that goes well beyond eye care. So the eye is one of the few places in our body we can actually see blood vessels, see nerves directly without any invasive procedures, without doing any cutting, without doing any injecting any dyes. And so what that means is that it can reveal signs of diabetes, high blood pressure, some neurological conditions. And that can even be seen while someone still sees 20/20. They still see great. Sometimes patients are having symptoms, but they either go, "No, I'm sure that's nothing," or they just kind of blame it on another condition that they may have. But when access to primary care is limited, that early detection can genuinely be life-changing. I think if you talk to any optometrist that you know, we will all have an experience where, we were the first person to detect someone's diabetes or high blood pressure. I think of a case that I had where that person had really high blood pressure when we sent them to their family doctor and could have been life-saving. So when we're talking about expanding optometric access, it's really talking about two things at once: improving eye health outcomes and helping reach people who are already underserved by the broader healthcare system, because eye health is an important part of our overall health. And so with that in context, I want to talk about some of our barriers that we're seeing along the way. So a little bit about me first. As Leslie mentioned, I practice in Halifax, Nova Scotia. I've been there for 20 years. And so I'm fortunate to be in a larger city, and I have great working relationships with my ophthalmological colleagues in the city. I actually grew up in Gander, Newfoundland, which some people may know. There's been a bit of media buzz around Gander in the last few years because of the care and compassion that the community opened their doors to the world after 9/11. I wasn't there at the time, but certainly my parents and my friends and families were all part of the support that was there. And for me, growing up in this small town, it was the biggest town in the area. I thought it was a big area. I thought it was huge. It's 10,000 people. It's not huge. But so for me, my grandparents were even more rural than that. And so actually now my dad's moved back to the town he's grew up in, which is called Tollingate. And it's really it's on the coast. It's on the edge of the island. And so it is really quite rural. And, seeing those experiences of my family there gives me that perspective. In addition to that, early in my career, I actually did some locums in Gander. So I would go and cover vacations and things like that for the local optometrist. And so I've seen firsthand some of those challenges that rural Canadians can face. And I also know that, access in these rural communities, but it's not exclusive to them. Following up on what Angelica had said, people are having access issues. It's not just small towns or really rural and remote. There can be access issues in cities, in the suburbs. There are people who are falling through the cracks because the system is overstretched. And so there are a lot of numbers, so I'm going to use a lot of numbers. There won't be a quiz, don't worry. But really the numbers tell part of that story. So Canada has more than 7,000 optometrists compared to fewer than 1,400 ophthalmologists. 76% of Canadians travel less than 30 minutes to see an optometrist, compared to only 60% for ophthalmology. And while 62% of patients wait more than a month for an ophthalmology appointment, with 12% waiting more than 6 months, only 23% of optometrists report having a wait list at all. And the median wait time is just 4 weeks. So what this tells us is that optometrists are the most accessible part of the eye care system. And the question about if we're making full use of that, and right now, I think the answer is it depends. It depends on where you live. I'll use emergency care as a good example of where the gap can show up the most starkly. So nearly half of the optometrists across Canada are seeing emergencies cases every day. So flashes of light, floaters, sudden vision loss, eye pain, red eyes. And again, we are all doing this day in, day out. And so when a patient needs urgent care, 42% of Canadians say that they'll contact their optometrist first, well ahead of the family doctor or the emergency rooms. But that also means that 58% are not contacting their optometrist first, and they're finding other avenues. And sometimes the system just isn't set up to support that. So studies from the emergency room departments across the country have found that the majority of ocular complaints presenting to the emergency room falls within the optometric scope of practice. And yet those patients are often going to overcrowded emergency rooms, where research shows diagnostic accuracy for eye conditions can be significantly lower than what optometrists can achieve. We have more equipment accessible in our offices every day to do that. We also have examples from the UK, where there's formal pathways developed to build channels for urgent care to optometrists that between 75 and 97% of those cases can be fully managed without an onward referral. And those models have been associated with nearly 40% fewer emergency eye department visits. So there's no reason we couldn't build something similar to that here and even try. I think there's examples, and there's isolated examples that, you can find throughout the country. One for me in my practice is I have a large employer in the region that They actually send their, any foreign body that they have, they send to our practice instead of sending them to the emergency room. And that works for ICE, but it's isolated. And so, finding more broader processes to do that, I think would be really helpful to support our colleagues that are trying to do the best they can in the emergency room. So this kind of brings me to what I think is one of the most significant barriers, which is just the inconsistency of optometry scope of practice across the provinces and territories. So, why does this matter? Scope of practice is how the government defines what a regulated health professional is legally permitted to do. But that definition doesn't always keep up with what their education and the training actually prepares them for. So as research advances, clinical care evolves, scope needs to evolve too. And when it doesn't, you end up with highly trained professionals who are legally prevented from providing care that they are qualified to deliver. So in Canada, where provinces regulate healthcare, it means that the optometrist can do varies from province to province, even though their training is more or less the same. And this has a real impact on the care that Canadians get. So more than 8 million Canadians are living with conditions like glaucoma, cataracts, diabetic retinopathy, age-related macular degeneration. And these diseases disproportionately affect our older patients. And as Canadian population ages, those numbers are only going to rise. And on top of that, we're only just learning the long-term impact of the growing myopia epidemic. So as we see children progress with myopia earlier, we know that this increases their risk of high myopia, which can increase their risk of vision issues later on in life. So for many Canadians, vision loss isn't just a clinical issue. It affects the ability to work, to drive, to read, to live independently. It increases the risks of falls, which comes with a lot of other complications. So when people can't access care, it can touch every part of their daily life. So expanding optometric scope isn't just simply a policy opportunity, it's a public health necessity. We already have evidence of what that looks like in practice. When optometrists were granted the ability to prescribe topical medications, studies show that there was a 12% decline in vision impairment, particularly among racialized populations that historically faced the greater barriers to care. So a concrete example of this is acute angle closure glaucoma. And that's when the angle where the fluid drains out of the eye closes, and it can cause a pretty fast and pretty high pressure spike. So it's different than the primary open angle glaucoma that a lot of people are familiar with that can be very slow progressing. Acute angle closure glaucoma is a true medical emergency that can cause permanent vision loss if it's left untreated. So in many jurisdictions in Canada, but not all of them, an optometrist can prescribe the medications needed to stabilize the patient right away before they get to an ophthalmologist for surgery. And that quick response can mean the difference in saving someone vision or losing it for good. And it's worth noting that optometrists are considerably more accurate than emergency physicians at diagnosing these kinds of urgent ocular conditions in the first place. We have the equipment and the tools that we need to detect that in our practices. So getting to the right provider faster means better outcomes. So similarly, some provinces like Ontario have a list of medications that they can prescribe for optometrists. And that can create challenges as new medications become available. So in Nova Scotia, where I practice, I can prescribe topical eye drops for conditions like dry eye and glaucoma. And if a new medication becomes more available, that new medication may be more effective, it may be safer for the patient, and I can prescribe that. But for my Ontario colleagues, optometrists have to wait for that medication to get added to the list before they can prescribe, so possibly limiting treatments and possibly the access to the most effective medications for their condition. So it's the same condition, it's the same training, but it's different standards of care. And close to that example, there is also then the disparity in provincial drug coverage. And I'll speak to my experience because each provincial drug coverage is different. But for myself in Nova Scotia, I can prescribe medicine for dry eye. And if a patient has private coverage, it's covered. But if they're using the provincial pharmacare program, it's not covered. So I've actually had some patients stop the medicine that's making their eyes feel better because it's not covered anymore and it's not in their budget. This is dictating the care that we give. It's limiting the care that we can give. And this may be different from province to province when it comes to the provincial drug coverage, but it certainly can be frustrating for us, for these patients and the practitioners, when we see these barriers in place during their care. And I use the example of dry eye, and I know, it can be very impactful in someone's life. And especially for our patients who have glaucoma, sometimes they can experience that at a higher rate. So we want to be able to treat all things, right? And then on top of that, then the urban and rural divide makes all of this worse. So I have a slide, and it is actually a picture of Tullingate that I talked about earlier. It's my favorite hiking trail. And these beautiful cliffs and rocks and water. And I have family members who live there, and one of my family members who is there actually has age-related macular degeneration. And so to preserve his vision, he needs regular eye injections. And for a while, the closest ophthalmologist for him who could treat him was a 5-hour drive away. And he was lucky. He has family in the city of St. John's that he could stay with, which takes some of the financial strain off. He's retired. His daughter, who is driving him, is also retired. So it alleviates that absenteeism from work that is a concern for a lot of patients and a lot of their caregivers as well. And I will say this story does actually have a happy ending. There was an ophthalmologist that returned to the region, and now he can get his care much closer to home. So that's great. But a lot of patients aren't that lucky. They're dealing with travel costs, time off work for their caregivers. Certainly we see it a lot of times that, we have patients who may be older and they don't want to, ask their family, their loved ones to take them to the appointments. And their family is happy to do it. But a lot of times people are just don't want to put that on them, right? But there's a lot of physical tools for making these long trips. And at the end of the day, we're all still dealing with a serious condition. But his situation certainly is the exception, and it's not the rule. And so that's why optometry, with more practitioners and more locations, shorter wait times, can be a meaningful part of the solution. And so are there other solutions out there? You might be wondering, where does teleoptometry come in? And I think it does have a role to play, especially for screening and for follow-ups, but it does have its own limitations. So a lot of screening programs are only looking for one condition, and so we want to be careful that if we're screening for, say, diabetic retinopathy, that the patient knows that that's what we were looking for, that they still need to have a full eye exam to be checked for cataracts, for glaucoma, and for those other things. So we worry that sometimes that patients may go like, oh, great, I'm good. We want to make sure that they have access to full, comprehensive eye care. As teleoptometry evolves right now, it's really not there to replace full in-person care, but the technology is evolving, and we're going to see where this may start to change and its role may start to change. So I'm just going to pivot for a little bit. So I think workforce is another piece that I do want to talk about, and because I really don't think it gets enough attention. So getting more optometrists into underserved communities isn't just about training more people. It's about where the training happens and what supports exist to make rural practice a viable choice. So currently, Canada only has 2 optometry schools, one at the University of Waterloo and one at the Université de Montréal. That means that half of our Canadian optometrists are actually trained in the United States. And in some provinces like Alberta, that number is actually 60%. And so for, living in Western Canada, living in Atlantic Canada, if you want to be an optometrist, you're either looking at picking up and moving to Quebec or Ontario or to the United States. And it's a big move away from your family, your support systems, and it can also be an expensive one on top of tuition and all those other things that are already significant. And so I think there's a lot of people out there who don't see optometry as a career simply because it seems like the barriers are too great. But there's actually 2 initiatives that we're working on right now that could change that. There is a proposed optometry school for New Brunswick, for Atlantic Canada, and another one in development in Calgary. So getting people trained closer to home, I genuinely believe, will help get more optometrists into the communities that need them. There's also a place for the federal government to have a role by adding optometrists to the Canada Student Loan Forgiveness Program. Pharmacists, dentists, physiotherapists, they're already on that list. Optometrists aren't. And I do have the opportunity, my role as president of the Canadian Association of Optometrists, that I get to go to a lot of the schools, both in Canada and the US, and talk to optometry students. And the number one thing they want us to advocate for them is for the Student Loan Forgiveness Program. And I get it. Like, I think back when I was preparing for this talk that, 20 years ago, when I was deciding on where I wanted to go and, I could go home and set up in small town and I could go to a city, I think if this was something that was on the table for me, I think my choice would have been different. And I probably would have been practicing rural and probably would have stayed. So, I've been talking about these barriers broadly and access across provinces, the rural and urban communities, but I really can't talk about equitable access without talking about our Indigenous communities specifically, because in many ways they're dealing with all of these barriers compounded at once. So nearly half of our First Nation adults in First Nation communities live in rural areas, another 15% in remote and hard-to-reach places. Inuit communities are amongst the most geographically isolated in the country. So the federal non-insurance health benefits program, most people know it as NIHB, is essentially a benefits program eligible for First Nations and Inuit individuals that cover things like provincial health insurance doesn't, including vision care. So unfortunately, it has significant gaps in what it covers, in how consistently it's applied across the country, and how well people actually understand what they're entitled to. And we can see the results. In a 2018 study, only half of First Nations adults and youth had had an exam in the year prior. With diabetes rates in First Nations populations are 3 to 5 times higher than that in the general population, which means far higher rates of diabetic retinopathy and higher risk of visual impairment from that. First Nations youth have a higher rate of blindness and serious vision loss, yet only a third are getting the ongoing treatment. So among Inuit children, myopia rates are at 45%. And while we have good tools now to manage myopia and reduce the long-term risk, those tools cost money that NIHB doesn't always cover, adding more barriers to treatment that would improve their outcomes. And these aren't random outcomes. They're the result of colonial policies whose effects are still being felt today. Addressing them means more than one-off programs. It means building lasting relationships with Indigenous communities and developing care that reflects their priorities and knowledge, not just ours. So I know firsthand that change is possible, but it takes persistence. So before I became president of the Canadian Association of Optometrists, as Leslie mentioned, I spent years on my provincial board, and I served as the president in the past. And so one of the things I'm most proud of is helping push through change in regulations that finally allowed optometrists in Nova Scotia to diagnose, manage, and prescribe for glaucoma directly. We built the case, we took it to government, and found people willing to listen. But it took 6 years to get from, yes, this is a great idea, to actual change in the regulations. So it was 6 years of showing ups, having discussions again and again, continuing to keep the pressure on. And we had some really great advocates alongside of us, like Louise Gillis of Sydney, who I think many of you know as her years as the national president. I was hoping you were here. And so thank you for your work and your support with that to see this come through in Nova Scotia. So Louise is our former past president of the Canadian Council of the Blind. So when we finally moved things forward, there was this kind of perfect storm that was created. There was a regional crisis, there was a shortage of specialists, and enough public and political pressure that the government had to act. So by the fall of 2019, Cape Breton Island, so in the northern part of Nova Scotia, it's beautiful, I recommend it, was down to 1 ophthalmologist from 5. So it was a genuine crisis. And finally, in the late 2020, right, the regulations changed. Optometrists could finally do what their training had always prepared them to do, and some of our colleagues, for an Alberta example, had been doing that for many years beforehand. And so that experience taught me something that I carry into everything I do on the national levels. We can't do this alone. So we've spent more than a decade making the case that eye health and vision care needs to be treated as a population health priority. We are genuinely encouraged when the Honourable Jody Sgro championed Bill C-284, the act to establish a national strategy for eye care, and even more so when it received royal assent in 2 years. So we've put together 5 sets of recommendations during the Health Canada consultation process, including one focused specifically on Indigenous health inequities. And we're looking forward to seeing how those land when the strategy is tabled in the coming weeks. But a strategy on paper only matters if it works in practice. And it only works in practice if the people it's supposed to serve have a real hand in shaping it. And that's all of you. So patient advocacy organizations know things that no policy document can capture, where the system is actually breaking down, whether it needs to, and whether the promises are actually getting delivered to the people who need those. So this strategy needs to be built with you and not just for you. And we won't get it right without you. And I look forward to working with all of you in the upcoming years as we see this policy take shape. So thank you very much, and I'm happy to answer any questions.
Thank you. So again, we have a mic. If you have any questions for Dr. Scott, please feel to put your hand up and we'll bring the mic to you.
Hi, Allison. Great presentation. Thank you. So I'm Nina Ahuja. I'm president of the Canadian Ophthalmological Society. So optometrists and us are very much colleagues in this space. I appreciate all the data that you showed before, because it is true that we do have many, many more optometrists than we do have ophthalmologists. And so I'm also very impressed by the organization of scope expansion that optometry has done across the country. You've basically lined up the provinces very nicely. My question is, so for those who, everybody in this room is probably familiar, the difference between optometry and ophthalmology is we're both educated in eye care medically. Surgically is the area of ophthalmology where we've done medical school first, and we've done 5 years of additional training. So my question is in the scope expansion, I believe that we do need to increase and optimize everyone's scope. Within the discussions that are being put forward, though, I'm curious as to why ophthalmology has not been consulted in the process. Because as an ophthalmologist, I agree we need your help. I agree we should be working together, that there's a huge role for optometry to play. Some of the scope expansion requests that are moving forward involve procedural and surgical things, which are in the realm of ophthalmology, having done medical school and surgical supervision, practice, all of those things. So that's something that is curious to me, because we want your help. We would love to work with you to figure out how we can optimize optometry so that we can do less of certain things that optometry does have the skill to do within current scope. So I was wondering if you could comment on that.
Sure. Thanks for the question. You know, optometry is, while we are in the same space, optometry is a self-regulated health profession. And so, you know, when we're talking about scope, you know, the realm of the asks that are within that are in what are being taught at the accredited schools of optometry across North America. And certainly we look at, there's a few different things that we're looking at, and some of the examples I gave for today are things that we're just trying to get some of the provinces to the same level, like drug lists and things like that, which have, you know, unfortunately, you know, ophthalmology has resisted in that change, even though other provinces across the country are doing it. And we're certainly happy to work together and support each other. But at the same time, you know, when we meet some of that resistance of things that are happening in other provinces, it's really hard to then kind of come with good faith, unfortunately. But, you know, really the things that we're asking for are things that are taught at optometry school, and have things in place like additional training for those who didn't learn it in school, and also a separate exam so that not everyone will be doing the things that are being asked for. There will be safeguards in place. And so I think, I mean, I don't have a good answer for you. There were public consultation periods where certainly ophthalmology could provide their voice for that as well. So, and I think BC is an example of that, where ophthalmology was consulted and they've been working together in their scope asks.
Yeah, I would just say, and I appreciate that, and I know that historically there has been resistance, but with new leadership, as us as new leaders in the space, I would love to see us having conversations, because I think if we are directly speaking to each other, not going via third-party consultation process, I think we could help move things forward in a way that's really going to help us achieve the support we need and help you achieve your goals as well. So I would just put that out there.
That's fair.
Yeah, thank you.
Oh. I have a question here.
Hi, I just wanted to ask, between your presentation and the first one, like, it sounds like each province, like it said 2004 was Ontario defunded eye care. So are all provinces now no longer funding eye care, or some of them are and some of them aren't? Like, how do we get all of Canada on the same eye care package?
That's a great question, and you're right. And Ontario still has some coverage for seniors and children and people living with certain conditions. And a lot of provinces have something very similar to that. So in Nova Scotia, where I practice, children up to the age of 9, seniors over 65, and then people living with cataracts, macular degeneration, diabetes have coverage as well. But, you know, from Atlantic Canada, PEI has some coverage for children and people with diabetes, but also New Brunswick, Newfoundland has no publicly funded coverage other than social assistance programs. And I would say, you know, my experience, and I haven't practiced in Newfoundland in probably 15 years, but my experience there was that people would come in for care later because of you know, the lack of coverage that was there. And so yes, it would be great. That's a great question. It would be great to see that similarly across the country, but unfortunately, because healthcare is provincially funded, we do see those barriers and those differences across the country. But yeah, it's a fabulous question, and I wish I had an answer. Sorry? All province, so the only provinces that don't have any coverage would be Newfoundland and New Brunswick, and all other provinces have some form of coverage for usually children and seniors, and then people with certain conditions, but then there's nuances in each province from that.
My name's Joanne. I'm a CNIB client and I'm also with the CCB. My question is how come optometrists are not telling us, the client, what is covered and what is not covered? Because my optometrist keeps changing his way of saying something like my eye exam is covered, and then every year, and then the next minute he's saying I have to wait 2 or 3 years, and I have a special eye condition. So I'd like to know why this is happening for clients.
Do you mind if I ask if you live in Ontario?
Yes, I do.
Okay.
I live here in Ottawa, actually.
Okay, great. I know the Ontario coverage just a couple years ago changed, so it might have been, unfortunately, that they did pull back on some of the coverage that they have. So I think it might have been just falling into when that change happened, that what covered for you, unfortunately, sounds like you decreased. So I suspect that that's why all of a sudden it feels like, well, that's weird. I was covered every year. Now it's every, 18 months or 2 years. And that might be why. It's just the Ontario government did pull back a little bit on what was covered for optometric services.
Well, I just wish that my eye doctor would wonder why this is happening. Like, the government is not saying anything. And then me being a client of that certain doctor, it's like, oh, okay, all of a sudden I've got every year my peripheral loss is being checked, and then the next minute it's not. Mm-hmm. And, as you age, being a client, your vision does change. Mm-hmm. So the thing is, it just doesn't make no sense to me.
Yeah. And thank you for sharing. Hearing stories like that certainly helps with, our advocacy work when we are bringing this forward and have those conversations with government. It's those real, personal stories that really help bring message to the people who are making those decisions and the impact it is on you, that the changes that were made. So thank you for sharing your story, because that's how we can make change. I really appreciate that.
Hi, it's Jennifer Urosvik here from Vision Loss Rehabilitation Canada. My question is really about the education piece. I was really excited to hear, and I've been following, I'm from Kitchener-Waterloo, so of course I know Waterloo very well, about the expansion of education. We also struggle in our organization with qualified and hiring of education people in the education system to come work for us. What has been sort of your response? So I know you have Calgary and New Brunswick. How soon, I guess, would those schools open, do you think? Or where are you at your advocacy there?
I think we're still early on. The advantage I think that we have is that both will be satellites of the University of Waterloo. So it's not just building a new school from the ground up. I think if you talk to most optometrists, I know when I was in school, there was going to be a new school in BC and it was going to happen this time. That was 20 years ago. And so, you know, I think that this really feels like it's gaining traction. So we're still fairly early on, but the school in Alberta is a little bit further along, I would say, than the school in New Brunswick, and they're optimistic that if everything continues, that they'll be able to have a class start, you know, in 2028, 29, so not that far in the distant future. So we are very optimistic. This feels different, I think, than some of the other announcements we've had in the past, and I think the motivation's a little bit different now.
I have a question online here. It's regarding eye care providers and the increase of patient management demands. The question is, why are foreign-trained optometrists with many years of experience still unable to practice in Canada? And what is the optometry regulating body doing to address this issue? I know this might not be the question for you to answer, but if you have some idea.
I will do the best I can. I will say that optometry does look very different around the world. And so we want to make sure that, you know, people who are going to be practicing in Canada, we have the similar education. The National Regulatory Organization does have an exam that someone who is foreign trained they can write to see see where they would fit in, and then they could do the last 2 years at the University of Waterloo to complete their optometry degree in Canada to get trained. So there are pathways, you know, acknowledging that 2 years is a long time. So it is something that is continually discussed on that level, and you know, it's always an evolving target. So it's not something that it's just a no. There are pathways there for those individuals who are foreign trained.
Hi, Mohammed Salim, Canadian Council of the Blind. I have a question about the schools, optometric schools. No one can argue that we need actually a new optometric school in Canada. My question is, why in 2026 we didn't have one until now? Is this something gonna hurt the practice in the long run? And if not, how is gonna be like benefiting like the practice, optometric practice?
I think having more schools will help those. So there will be some Canadians who will still choose to train in the US, and that's great. There's fabulous schools in the United States, and they have excellent education. But there are some people who would like the opportunity to gain that education in Canada at home. You know, there is extra cost if you are going to go to the US to train with tuition and things like that. And so it just is to allow some of those Canadians who are being trained in the US to have the option to be able to train at home, and I think also closer to home as well. So when we talk about rural, I know for myself, again, I grew up in a really small town in Newfoundland, and the move to Waterloo was a big adjustment for me. It was the first place I ever lived with public transit. It was, so, you know, and there's probably a lot of other people like myself. You know, I was fortunate as a child, I got to travel, I've flown, all of those things. I had a classmate who had never left Nova Scotia before he drove to Ontario to go to optometry school. And the reason I bring those stories up is because those of us who grew up rural, I think, are more likely to go back to rural areas in those spaces. So we want to have opportunities for those people who, for whatever reason, it might be family, you know, have family commitments that you want to stay closer to home. It gives them the opportunity to have more options in Canada to be trained. Does that answer your question? Okay, thank you.
And I have another question here online regarding the schools as well. You may have addressed this a little bit earlier. Just what are the timelines for those schools opening, if you know that? They wanted to know how soon.
So the school in Calgary, I think, is further along in their planning process. I would say they're optimistic for 2028, 29, but certainly no dates are like set in stone. I think the school in Atlantic Canada is probably looking a few years later than that, but we're still very early on in those discussion processes. So I don't want to be held to any timelines here. If there's anyone who's planning to become an optometrist, I'm like, yes, the school's going to be there when I'm ready to apply. Yeah.
Do we have any questions in the room left?
Hi, hello. Hi, it's David Wood speaking. Thanks so much for your informative talk this morning. I'm wondering, what potential do you see for technology in terms of providing diagnostic support or analysis and remote care in the future, near future perhaps?
That's a great question. You know, I think technology is changing so quickly. And, you know, with AI-assisted devices and things like that, you know, we may see more, you know, at-home technology that possibly we could have. You know, we certainly will maybe see the improvement of of telehealth and teleoptometry continue to evolve and change that can support people who are living remotely or even have struggles, you know, accessing care, getting to the clinic that they need to get to for various reasons. So I think in the next few years, just watching things as a new technology is sort of exploding. I don't think it's that far into the future, and it's certainly, we want to be careful that if we are using something that is, you know, AI assisted or whatever, that it's doing a good job, that we know that it's not replacing, you know, your in-person visits, your comprehensive care. But if there's a way to maybe watch your disease more closely at home, I think there might be possibilities of that happening. And then when we look at other devices, like a lot of these smart glasses and things like that to support as visual aids, I think there's a lot of potential space there as well. So yeah, I think it's kind of an exciting time right now, because with the way that technology is changing and how quickly, I think there'll be a lot more ways that we can track and detect and monitor disease more closely.
I think that's all.
Thank you so much. Thank you. So, thank you very much, Dr. Scott. I just wanted to add a couple little notes myself about our two conversations that we had this morning. We know here in Canada, across the country, from province to province to province, healthcare as well, and particularly vision care, is very uneven. We know that. And I won't go into the National Eye Care Strategy, because a little bit later on, we're going to have Jennifer come up and talk about that. But I would like to say that on behalf of CCB and the coalition, the one thing that we do wish to advocate for in the National Healthcare Strategy is to level the playing field. Let's get everybody started off on the same foot, and then we can just grow from there across Canada. So I think that's one area that we're all very aware of, and let's hope for, if we can just level the playing field, we'll be starting off in the right direction. So we'll hear more about that later on. So we at CCB, we would like to announce a very special campaign that we have coming up. And up on stage with me today is Jim Tokos and Jessa Ross. Jim will go first.
Should be ladies first. Thank you. What happened to this ladies first thing? Anyway, I'm proud to officially announce the Right to Sight campaign, launched by the Canadian Council of the Blind. So the Right to Sight campaign is a national program, and why it matters to us is, and I'm going to continue along the lines of statistics, so bear with me, please. So 1.2 million people in Canada live with vision loss or significant vision loss, and I'm one. I'm not scared to admit it. And the other major point is that 8 million people living in Canada are currently living with an eye condition, which, if not detected early, can cause further vision loss. Because if it's detected early, it can be corrected. So that's a lot of people, and that number is growing all the time. And we heard a lot of talk about the differing disparities across Canada with eye care and eye exams. So that even creates more of an issue. I think we have to, and hopefully we can get some consistency across Canada for people to get proper eye exams, and so everybody takes the time to get their eyes checked regularly, and we get some, like I say, some consistency across Canada. So, thank you.
So the purpose of the campaign is to raise awareness about vision health and preventable blindness. We are gathering evidence to identify gaps in care and inequities across Canada. By advocating for equitable access to care, treatment, and supports, we will connect and help educate policymakers, healthcare professionals, and the public. We know how important data and lived experience is. Data helps us understand the scope of the problem. Lived experience helps us understand the human impact. And we need both evidence and real stories to drive meaningful policy change. The voices of Canadians living with vision loss must be at the center of decision-making. So how are we doing this? Through national evidence gathering, creating provincial and territorial scorecards, by developing educational tools and awareness resources, by growing national outreach and partnerships, and conducting stakeholder interviews and surveys. After all, no Canadian should lose their sight because of barriers to care. Now, I'd like to speak about one simple but powerful action: adding your voice to the Right to Sight survey. We're collecting this data because numbers alone don't change systems. People do. Behind every statistic is a lived experience. Someone waiting too long for care, someone struggling to access affordable eye exams, someone navigating vision loss without the support they need. These experiences are not just individual stories, they are evidence. And when we bring them together at scale, they become impossible to ignore. So right now, decisions about eye care are often made with incomplete information or incomplete data. We all know this. And without consistent national data grounded in lived reality, policy can drift away from what people actually need. That gap contributes directly to delays in care, uneven access across provinces, and in many cases, preventable vision loss. So the purpose of this survey is to close that gap. What we plan to achieve is clear and practical. First, we want to establish a credible national benchmark for what equitable, accessible eye care should look like in Canada today. Not assumptions, not estimates, but real data based on real experiences. Second, we want a province-by-province picture that highlights where the biggest gaps exist. Eye care is not experienced evenly across the country. Again, we all know this. And this survey will help pinpoint where people are being left behind so that leaders and decision makers know exactly what action is needed most urgently. And third, we want to turn insight into accountability. That means identifying tangible commitments, whether that's improved coverage for essential services, reduced wait times for specialist care, or stronger rehabilitation and vision support programs. And tracking these commitments publicly over time so that progress is measurable and not just promised. So this is why your input matters so much. Even a few minutes of your time can help shape decisions that affect access to care for years to come. So please take the time to complete the survey at right2site.ca. And if you can, share it with your network. Let's get as many voices as we can. So the more voices we hear, the stronger and more accurate the picture becomes. So now I'd like to invite Jessa up, and she will walk us through the technical side of the survey, how it works, how responses will be handled, and how the findings will be analyzed and reported. Jessa?
Thank you, Leslie. So as mentioned, I'm briefly here to cover the technical aspects of our survey. So the Right to Site survey will consist of 40 or so questions that take about 10 to 15 minutes to complete. Our hope is to gather key data while avoiding that respondent fatigue that we often see. We're operating around several research questions informed by 8 pillars. So, we want to understand where and why Canadians are experiencing barriers within the vision care system. And another major focus is understanding the levels of public awareness around preventative eye care and early detection, and whether gaps in this awareness are contributing to delayed treatment and poorer outcomes. Our survey is mixed methods, so it's quantitative and qualitative. Quantitative data will provide valuable insights on geographic and demographic trends in eye and vision health, while those open-ended questions tease apart the day-to-day experiences of Canadians accessing vision healthcare and disability supports. Our target sample is large. We're aiming for 1,000 respondents from across Canada, urban, rural, remote, and all walks of life. Our priority is a diverse range of participants to better understand geographic similarities and disparities. Quantitative data will be analyzed to identify patterns and correlations, while qualitative responses will undergo thematic analysis informed by what we already know about social determinants of vision and disability supports in Canada. Responses will be systematically reviewed to identify recurring themes, shared concerns, and common experiences that emerge across participant stories. This information will also set the stage for further research down the line when we pursue 130 semi-structured interviews with eye health experts, patients, caregivers, and public health officials from across the provinces and territories. Our goal is to contribute to the growing field of literature on Canadian eye and vision health while also establishing a firm foundation for our campaign. We believe that a strong awareness campaign should reflect the experiences of each of the provinces and territories, and the Right to Site survey is the first step. Thank you.
Thank you, Jim and Jessa. So we all know that there are disparities across Canada, and we also know that there is a lack of data to prove that, and policymakers need data. So CCB is really hoping, and our goal is to create the data that we could use when speaking to policymakers moving forward. So thank you, Jim, and thank you, Jessa, for explaining that. So I would like to introduce Jennifer Urosovich, President and CEO of Vision Loss Rehabilitation Canada. And as the chair of the Vision Health Partners Coalition, Jennifer will share updates on the National Strategy for the Eye Care Act and its ongoing advocacy efforts. Welcome, Jennifer.
Hi, everybody, and hi to everybody across Canada. It's great to be here as we wrap up Vision Health Month. And I really wish we had really good news to say that the implementation strategy has been tabled and we all know what the government is going to do, but we don't yet. And so I'm going to share some remarks on behalf of my coalition colleagues from across. I've made some notes. I've got some water. I don't know if it's allergies, but I'm just going to warn everybody that I may have to stop and take a little sip there. So it's an honor to be here today during Vision Health Month and to stand alongside so many passionate leaders, advocates, clinicians, and individuals with lived experience who are united by a shared purpose: advancing eye care and vision health across Canada. I'm proud to be representing the Vision Health Partners Coalition, a truly unique alliance that brings together the Canadian Council of the Blind, CNIB, the Canadian Ophthalmologic Society, the Canadian Association of Optometrists, the Opticians Association of Canada, Fighting Blindness Canada, Orbis Canada, and Vision Loss Rehabilitation Canada. What makes this coalition really powerful is that it's not just who's at the table, but how we come together and what we represent. We span the full spectrum of eye care. We represent every step of the journey, from lived experience, prevention, diagnosis, treatment, research, rehabilitation, habilitation, and community programming. And critically, we center the voices of people living with vision loss in that journey every single day. That breadth was not incidental. It is the foundation of everything that we do. Over the past few years, our shared goal has been to be very clear and elevate vision health as a national priority. One of our most significant collective achievements has been our shared advocacy in Bill C-284, the establishment of the National Eye Care Strategy. Working closely with the Honourable MP Judy Sgro, who tabled the private member's bill, the coalition helped demonstrate the power of a united voice in advancing meaningful system change. And we heard a lot about system change this morning from Angelica and from Dr. Allison Scott about how important it is to come together with that united voice from an advocacy perspective. This is not the work of one organization. It is the result of partners coming together for one voice. Together, we have engaged members of Parliament, senators, we shared evidence, amplified lived experience, demonstrate the urgent need for a coordinated pan-Canada approach to vision care. Many of us had the opportunity and privilege of testifying in front of the Senate, bringing forward not just data, which is important, but real stories of Canadians navigating sight loss and the gaps that exist in the system. And because of that collective effort, we saw Bill C-284 pass through the House of Commons in 2024 and later pass through the Senate, receiving royal assent in November of 2024. And now we're all on the edge of our seats to see what this strategy looks like. That moment is more than just a milestone. It is a signal that vision health matters, that Canadians deserve equitable access to care, prevention, treatment, rehabilitation, habilitation, and support, no matter where they live in this country. We all know that passing a law is just the beginning. The real work is on the implementation. And once again, the Vision Health Partners Coalition leaned into collaboration. Following the passage of the bill, we came together and developed and submitted a unified set of recommendations to Health Canada. And I want to take a few minutes to share those recommendations and what that process looked like, because many of you were probably involved. Let me start with the scale of what we undertook. From late June of last year through to September, we engaged over 800 stakeholders across Canada through our support with Santis Health. This was not a box-checking exercise. We ensured that we conducted 28 key informant interviews with clinicians, researchers, system leaders, policymakers. We held focus group with individuals with lived experience of vision loss who generally shared their daily realities. We surveyed 285 vision health workforce professionals, including optometrists, ophthalmologists, opticians, orthoptists, vision rehab specialists, orientation mobility specialists, low vision specialists. And we heard from 512 Canadians living with vision loss through our survey. I know my team, I'm sure, got sick of the survey, but I made sure that their voice mattered. Then we brought that knowledge to a full-day retreat in Ottawa here, where the coalition members reviewed the findings together, and we began drafting recommendations, followed by a series of virtual workshops to prioritize and finalize our submission. The result of the unified recommendations was 17 recommendations organized around themes of equitable access, integrated health systems, awareness, education, research and data, and strategy implementation. Let me highlight a few of what we put into our recommendations. From a governance perspective, we called on the federal government to establish a strategic steering committee that includes people with lived experience and the full range of vision health professionals, researchers, to ensure that decisions reflect the needs of Canadians. And alongside that, a vision health desk as a dedicated hub to coordinate. From an awareness perspective, we recommended a national public awareness campaign. We heard this morning, still too many people don't access eye care that is either available in their communities, more so sometimes because they don't know where to turn. On the data side, we asked for a national data infrastructure because right now, Canada lacks consistent, comparable data on vision health prevalence, wait times, workforce, and outcomes. We rely on self-reported metrics and US data sets. This is not acceptable for Canadians. On access, we recommend that the federal government work with provinces and territories to develop coordinated, person-centered pathways from prevention all the way through to rehabilitation and community programs, ensuring that no wrong door approach, so that no matter where a Canadian shows up in the system, they find the supports they need. When we spoke directly to the needs of Indigenous communities, vision loss rates among Indigenous Canadians, particularly children, are high. Indigenous children experience high risks related to non-Indigenous children. Rates of diabetes, the leading cause of working age blindness in Canada, have risen 20% in the Indigenous populations over the last 2 decades. I think that supports some of the data and the numbers that we heard today. On the research side, we called for dedicated funding across the entire spectrum of vision health research. And finally, we recommended streamlining of regulatory pathways for drug and medical devices because Canadians are waiting 4 months. And included in there is, when we talk about device programs, we're talking about programs that put equipment in the hands of people as well. The economic case is compelling. In 2019, the total cost of vision loss in Canada was 32.9 billion. Without action, that is expected to reach 56 billion by 2050. Early detection, prevention, access are not costs. They are investments that pay for themselves over time. But the human cases that drives us is the over 8 million Canadians are living with a condition that could lead to vision loss. Many preventable and treatable, yet too many people still face timely care, gaps in services, inequities based on geography, income, language, or simple lack of awareness. The national strategy gives us a once-in-a-generation opportunity to change this, but will only succeed if we work together across sectors, across disciplines, across lived and professional experiences. And I'm excited to share that we're taking another concrete step forward. Early, hopefully next week, we will be launching the Vision Health Partners Coalition joint website, a first for our coalition and a signal of how far we've come. We will be sharing it all through each of our individual websites and social medias, but it will be launched as www.visionhealthpartners.ca. And we encourage you to share it broadly with your networks. This is more than a website. It is a shared home, a place where Canadians, partners, policymakers, and advocates can learn who we are, what we stand for, and how we're working together. It reflects our commitment to transparency, to coordination, and showing up as a coalition with one voice. Since submitting our recommendations in January, our work has continued to evolve. We have strengthened our coordination as a coalition, moving from alignment to truly looking at integrations about how we collaborate. We have clarified shared priorities, identified where we can leverage each other's strengths, and establish more consistent communication. And we're beginning to track our progress, our successes, and our challenges, so that we can continuously improve. We have also been engaging more intentionally with our federal partners, ensuring that this national strategy takes shape and it reflects the realities on the ground. Tomorrow, we will be hosting a press conference at the National Press Gallery, followed by meetings with key members of Parliament. And we've had honest conversations within the coalition and need to continue to do so about where the coalition is working well, where it is hard, and where we need to navigate different mandates while staying aligned on shared outcomes. But what truly matters about collective impact is the individual work that we do. It is not always easy work, but it is necessary work, because the challenges that we're trying to solve are bigger than just one organization. And the opportunity in front of us is significant. The Vision Health Partners Coalition is committed to being a partner in that journey. We are committed to showing up with a united voice to bring forward solutions, not just challenges, to holding ourselves accountable, not just to our organizations, but to Canadians. I want to take a moment to recognize the leadership and the commitment of each organization within the coalition. This work requires time, trust, and a willingness to think beyond traditional boundaries. And I also want to recognize the broader community here today and across online, because this work extends far beyond the Vision Health Partners Coalition. It includes all of you: advocate, service providers, researchers, policymakers, and individuals with lived experience. We all have a role to play. And as we look ahead, our focus is clear: to move from strategy to implementation, from commitment to measurable impact, from a fragmented efforts to truly coordinated system of vision health in Canada. If we continue to work together with purpose, with trust, and with a shared vision, we will have the opportunity to transform outcomes for millions of Canadians. Thank you for your leadership, and thank you to the CCB for having and bringing us together on this event, for your partnership and your commitment in Vision Health.
Thanks. Thank you very much, Jennifer. And on a side note, I would like to say that CCB is very proud to be part of this coalition, and we look forward to working with everybody in the years to come. So I would like to now introduce Catherine Langlois, Senior Universal Accessibility Advisor with Via Rail Canada. Catherine will be providing an overview of Via Rail Canada's current accessibility plan, outlining ongoing initiatives to improve inclusive travel across Canada. So welcome, Catherine.
Good morning, everyone. Are you able to see me? Because I'm a short woman, and with this pedestal, I know I do the same joke every year at the CCB Gala, but is everyone able to at least hear me? Yes? Okay, good. So my name is Catherine Langlois. I'm lead advisor in Universal Accessibility at Via Rail. I'm really pleased to be here with you today. As I was saying, I'm a short woman in her 40s. I have strawberry blonde hair, I'm short, I'm wearing black pants, a white blouse, and a black jacket today. I know it's noon, I'm probably the only thing standing between you and your lunch, but bear with me. I assure you that the next 10 minutes, because I'm gonna speak fast, but not too fast because English is not my first language, as you can hear. And you're gonna learn very insightful information, useful for you and your community. So I'm gonna present you this morning, I'm gonna walk you through Via Rail's accessibility plan. It's a 3-year plan that we have to do according to the Accessible Canada Act. So we have to identify barriers, remove them, and prevent creation of new barriers in 7 areas. The first area I'm going to talk about is information communication technology. You might be aware that we have sign language, virtual sign language available in some stations. For instance, here in Ottawa Station, this service is available. We've implemented that service as well in Montreal Central Station and Toronto Union Station last fall. So we're gonna move on and implement sign language upon request in other stations in the coming years. We do not know yet in which station it's going to be available, but it's going to be told, it's going to be published along the way. Now, the project that might interest you the most is the autonomous wayfinding project that we have here in Ottawa Station. We began working on this, I think, 2 or 3 years ago. We wanted to find a tool that would help our clients with vision loss to navigate a station autonomously. So we looked in different companies, different products, and for sure we wanted to have something amazing like ERA or Be My Eyes available in every station. But the reality is our budget would not allow us to be near that kind of service. So we tried, we tested an application called Good Maps for more than a year now. Some of you in this room have been part of the cohorts who've tested Good Maps. At the beginning, it was promising, it needed some improvement. We've tested the app 3 times now, and we saw big improvement, but we wanted to test another product to really have a better understanding of what was going to fulfill the needs of our clients with vision loss. We are now testing another application that is called Navilance, and it works with QR code. So we will go on testing that app for a couple of months, and then based on the comments that we will have gathered from our participants, we will decide with which we're gonna move forward, and then it's gonna be announced as well. For the built environment, the train stops in approximately 400 locations in Canada. On those 400 locations, only 80 of them are considered stations. And many of those 80 are in rural locations. So we do not have an accurate picture of the level of accessibility or the lack of accessibility of those stations as of today. So we want to do a gap analysis in regards to accessibility to then be able to make a full improvement plan with our colleagues from the Built Environment Department to make sure that we have a robust plan to improve accessibility on our station. But in order to do that, we have to begin by doing the gap analysis. Procurement of goods and services. We already have an accessible procurement process that it was implemented in our last accessibility plan. It works, but we are frequently told by our colleagues who often do tenders to hire services, to buy some equipment, that the process, even though it works, it's a bit heavy for them. So in phase 2 of the accessible procurement process, we want to work on making it easier to make sure that it's not a burden, because if it's easier, colleagues are more likely to strictly respect the process, and we're going to make sure that we're going to have more accessible services and equipment that we buy. Now I'm going to touch about design and delivery of program and services. Some of you might be aware that we had a pilot project to provide sensory support kits for our clients that have neurodiversity. It's a partnership that we have with Autism Canada. It began as a pilot project in the corridor, so between Quebec and Windsor. And this sensory kit is provided upon reservation, and it's free. So as you can imagine, the demand has been growing, because who says no to a free lunch? But it also means that there's a real need. So we have to work with our partner to make sure that this service is sustainable. So in this second phase of the project, we want to make sure that our process is more robust and sustainable, so we can maintain it throughout the years. And now I'm going to I'm going to give you a scoop. As for June 1st, VRL will be part of the Sunflower Hidden Disability Program. So it's beginning next Monday. We wanted to make sure that we were making a step forward in being more inclusive. I think that we improved a lot with the service that we give to our clients who have visible disabilities, but there's a real need to improve services for our clients who have invisible disabilities, so that's why we wanted to join that program. And I'm pretty sure it's going to be a success. We have talked a lot about it to our colleagues. Lanyards are going to be available in stations, not all stations, but the 10 main stations. And from now on, should anyone wear the lanyard or the pin, our staff will fully know what it means and will be able to adapt their approach to the kind of service that these clients need. Another important area is employment. VRL wants to be an employer of choice for people with disabilities. We made big improvement in our last accessibility plan. We revisit our hiring process to make sure that everyone has equal chances when they apply at VRL. Now we're going to implement the new accessible employment standard. And when I read the standard, I was really pleased and relieved that to see that VRL was already doing most of what was required in that standard. But there was one piece missing, and this is my segue for the next area, which is communication. But it's communication, everything non-digital. And so in the standard, it requires that our employees, our staff, have access to documents in alternative formats, which they do not have access to right now. So we already have a supplier, a provider, and we need to now put in place a process where our staff will feel safe requiring those documents, no question asked, it's gonna be confidential, it's gonna be simple. Well, we're gonna make many efforts to make it simple, but you know, in a crown corporation, well, crown corporation and simple don't really go along in the same sentence. Usually it's more like pushing an elephant through an icy hill, but that's another story. So we're gonna do our best to make it simple, easy, and confidential when our employees request documents in alternative format. Could be Braille, large print, audio, or anything else that they need. So this is something that we are working on. I also have allergies, so plus my French accent, I hope that you're not lost. I'm gonna have a sip of water. Just a moment, please. Last but not least, transportation. You might have heard that VRL is renewing its long-haul fleet. So for those who are not familiar with those services, long-haul fleet is the train that goes from Toronto to Vancouver, from Quebec to Halifax, and all the regional routes. So this means Jean-Pierre Saint-Terre, Sudbury White River, Winnipeg Churchill, Jasper Prince Rupert, and I'm perhaps forgetting one or two others, but those are regional routes. In January 2025, we did the first consultations with our accessibility committee and other participants from many advocacy groups to make sure that our concept would fulfill the needs of our clients with disability, because this is a train that will have many types of cars. We're gonna have sleeper cars, we're gonna have berths, we're gonna have diner, panorama, dome car, coach, and baggage car, but almost 9 different types of cars, and we wanted to have accessibility in every class of service and in every type of car. So that's why we wanted at first to make sure that the concept that we had in mind would fulfill the needs of our clients with disabilities. So we did that first consultation in 2025. Now, don't ask me who's gonna be the manufacturer. I don't know, and I would not be allowed to tell, but in the coming months, the contract will be signed, and then we will be able to move on with design. And this is when I'm gonna need you, because we're gonna hold new consultation on the design to make sure that we are still on the right track, and that if adjustments are needed and if we have to do some tweaks and perhaps redraw or do some improvement in the design that we had already began, well, it's gonna be due at the right time, because we do not want to retrofit such a big project. So this is what's gonna be happening in the coming months or year. I think I'm doing just right for the launch. Do you have any questions?
Hello, my name is Richard, and I used to be a rehab teacher with VLRC, and I'm also legally blind myself. First, I want to say thank you so much to Via Rail and all the great work you've done. I love train travel, and I have to say in Ottawa, the customer service is impeccable. The people on the train have been amazing. The level of accessibility is just incredible. Yes, there's space for improvement, but I'm just so impressed from 10 or 20 years ago when I've had some pretty horrific experiences and would thought I'd never travel on Via Rail again. So I'm really glad to see that it's come such a long way. My question to you is something happened recently that I think I understand, but hopefully you can clarify. I have a seeing eye dog or guide dog, and I've taken it on the train many times with just my CNIB card. But recently, I've had several emails requesting that you need documentation where my dog is from, if they're from a valid guide dog school. You want their rabies shots, all their medical, which I have no problem with, but I'd like to know where that policy and procedures come from, and are all disabilities being asked for the same thing, or is it just persons with guide dogs? If you could answer that, I'd really appreciate that. Thank you.
Thank you for your kind words, and thank you for your question. I was waiting for that one, to be honest. So, long story short, we had incidents of bitings with emotional support dogs. So we had to change the policy for emotional support dogs, which led to emotional support dogs are now not allowed to be on leash on the train. They have to fit in a pet carrier, so large emotional support dogs can't travel with us if they can't fit in a pet carrier. So what do you think happened? Overnight, large emotional support dogs transferred into service dogs. And now, again, long story short, we had many issues of dogs that were not properly trained, that were passed as service dogs. So this is where it came from. But when we understood the impact on the community of guide dog owner, the RL reacted promptly, and we consulted with our colleagues, Diane Bergeron and Jim Tokus, from the two main organizations to see how we can make a difference between what is required for guide dogs versus what is required for service dog. And let me reassure you, all the emails that you've received, you should have received at least one saying that this is on hold. You will receive new information in the coming weeks. So you will be able to travel with only the card as it was before, and it's gonna be a little bit different for service dogs.
Thank you very much.
Sorry, hi, I just want to do a
one more.
follow-up. Thank you for that answer, and that's what I was expecting. Just for people who don't know, and I know lunch is coming, so I'll make it really short. Try to anyway. I was expecting, I've already sent in my CNAB card back and front and my guide dog stuff and everything. I have no issue with that because a lot of people may or may not know this has been a really major issue for guide dog users. Having to deal with emotional support animals because anybody can just take their animal with no training, no legal documentation, anything. So I run into people on the bus that just put their dog, mini dog or whatever, cat in a bag and bring it on board, and it causes so much issue. My dog's, almost being attacked or, barked at or whatever. There's been so many issues. And even the Americans with Disabilities Act have restructured some of what they've said. And a lot of the airlines across North America have changed their laws or their rules regarding emotional support animals too. So this is a massive issue. I know the Guide Dogs for the Blind in California have put a committee together to work on this, and I hope CNAB and other CCB and AEBC are all working on this as well, because it is a massive, massive issue for all of us. And we're running into so many problems almost on a daily basis with emotional support. Every time I get into Uber or something like that, don't put your dog on the seat, don't do this, don't do that. And I'm like, this is a guide dog. You need to get educated. This is such a massive problem. So thank you, and I appreciate what you're doing, and I support what you're doing. Thank you so much.
Thanks you.
Thank you. Thank you very much, Catherine. And thank you for the morning speakers. Thank you for being here with us and sharing your expertise and knowledge. We're going to break for lunch. We'll come back roughly around in about a half an hour or so. So we'll try to take a few pictures if we can, and feel free to eat your lunch when we start the afternoon as well. So we'll have another guest speaker after lunch, followed by a panel discussion. So enjoy your lunch, everybody. Thank you. Good afternoon. So I hope everybody has been able to start their lunch. Please feel free to continue enjoying your lunch while we have our next speaker. Unfortunately, Dr. Sabri is not able to join us to talk about his ICEE project. However, Dr. Yasmin Jandani, who is a close colleague of Dr. Sabri, is with us online to give the presentation. So welcome, Dr. Yasmin.
Thank you. Thank you, everyone. I'll just start by giving my sincere apologies from Dr. Sabri. He would have loved to join this, and unfortunately, sometimes some cases come up that are unavoidable and he had to take care of. So I'm here today, and I've been working with Dr. Sabri since we first found this project in 2019. And we want to talk about our project we've developed called the Indigenous Children's Eye Examination. It's based on helping little eyes see big things. Next. So we're going to talk a little bit about the background of the program. I'll give you a little bit more in-depth information about IC, and then we'll have a few takeaway points for you as well. Next. I want to start by giving a bit of an acknowledgement. I recognize as a Canadian that the original inhabitants of this country have been marginalized. I learn compassion, sacrifice, and respect for all life forms from the foremothers and forefathers of this land. I strive to honor their past and help address the inequalities they still suffer. Next. So IC started, as I mentioned, in 2019. That is when we first had our first visit to the Hudson Bay, Ontario area. It's quite far north where a lot of the communities are considered like fly-in communities. This picture on the right that you can see is actually of Dr. Sabri, and then in the middle is our research assistant at the time, and then myself. And that was our very first trip to the northern communities, where we had already had many years, Dr. Sabri had had many years of talking with different chiefs and setting up the foundation for the program. And this was our first visit where we didn't actually see any children, but we really went to further build those connections within the community and see how things are being done before we actually made our first visit. And in that visit, I still remember the lack of eye care in the Indigenous children that was made very evident to us by other healthcare providers as well. Next. So our vision for IC is that we wanted to develop a national program for delivering high quality eye care for all Indigenous children across Canada. So that is, we're talking First Nations, Métis, and Inuit. And to do that, we then are going to use IC as a conduit for delivering healthcare beyond eye care. So I will go further in detail about that, where we have different pillars of IC that we now have. Next. I'm going to take a minute just to introduce some of the team. You can go next. So as you can see, this is myself. I'm the national coordinator for the project and the lead optometrist. And on the right, who's actually joined the meeting as well under Karush Sabri's thing here is Alexandra Wisness. So she is our administrative assistant and our vision screener for the project, and she's come on a number of visits with us as well. Next. So I'm going to take a few minutes just to talk about the importance of vision screening. Oftentimes, as you know, poor vision in children can easily go unnoticed. Children cannot, when a child can't see clearly, oftentimes the burden is invisible. There's no physical pain, as you know. So children tend to find a way to adapt quite quietly. And so sometimes you'll find that a child might come closer to the board. They might start to hesitate to participate in class. And oftentimes that leads to a child that falls behind without even knowing why. So good vision is key for physical, emotional, and social development. It can lead to when you have poor vision, it can lead to increased risk of blindness, mental illnesses, and depression. 80% of a child's learning is dependent on good vision, which is why it is so important. And we found that 10.7% of the general population have irreversible vision loss due to ocular disorders that were not treated in childhood. So that tends to be things like amblyopia that might have been undiagnosed. So the importance of vision screening is that approximately 25% of school-age children suffer from vision impairment. So that's just to say, out of every 4 children, 1 child tends to have a vision concern. And these common causes of visual impairment are things like astigmatism, which is at about 11%, myopia, which is nearsightedness, is 22.6%, and hyperopia, farsightedness, is at 10.6%. Children who are blind in one eye are often 3 times at higher risk of losing vision in both eyes. They're less likely to complete higher education, and they have decreased socioeconomic status later in life. So the current lack of eye care in children is shown by only 3% of children under the age of 2 have received an eye examination. And then we also find that in the next age category, that only 38% of children between the ages of 2 and 5 have ever received an eye examination. And that tends to be the key age group of 4 years where you start school. So that's pretty low. The fact is we'd want it to be closer to 100%, right? Before you start school, we want to make sure that all children are able to see properly. But again, only 38% of children are actually getting an eye exam. And after that, only 55% of children beyond the ages of 6 to 19 have received an eye exam. During COVID, we did a vision screening in Canada survey. I was the main author on this publication where we went and found out how many schools and how many public health districts were actually performing vision screening. This was after it was mandated by the Ministry of Health and Long-Term Care. And we found that many children with reduced vision were undetected. And 7 out of 13 Canadian provinces did not provide vision screening at all. And what we did also find was that there was inconsistent follow-up and especially training protocols. When you asked how they were trained to perform vision screening, a lot of times it was, we just have someone from the Lions Club maybe go in and they're not really trained on how to properly do those tasks. So how well are they actually doing the screening became a bit of a question. And again, this brings us back to the hidden cost of vision loss. So the reason it's so important for children is that approximately 1.2 million Canadians currently live with vision loss. And according to the World Health Organization, at least 2.2 billion people worldwide have vision impairment or blindness, of which over 1 billion cases could have been prevented or have yet to be addressed. And I think that's the big thing, is the prevention aspect. The total annual cost of vision loss in Canada is estimated at 33 billion. And in June 2012, the National Collaborating Centre for Aboriginal Health identified vision as an emerging health priority. So vision care in Indigenous children. So speaking specifically about that, we found that there's many health inequalities that begin in children. And Indigenous communities have large youth demographics, which is why it's so important. They have about 28% of children under the age of 14. there is a higher evidence of myopia within those children and astigmatism, which, as we mentioned, those are things that later on can lead to vision loss and should be corrected. So if there's a lack of access to necessary health care, that becomes the initial problem. So if we can increase, the other problem is the increasing prevalence of diabetes, which is a leading cause to increased vision loss later on. And I'm sure you're aware that that is something that within the Indigenous populations, diabetes tends to be a little bit more prevalent, especially with the type 1 in children. If it doesn't get diagnosed and treated at a young age, again, that's something that causes the lifelong vision loss. Next. Nearly 500,000 Indigenous children are living on and off reserves in remote parts of Canada, which is why this is so important. Here in the urban populations, we tend to have a lot of access to eye care, which is fantastic for those children that are actually benefiting from that and using it. But a lot of times they don't have the access. So that's something that when they're living on and off these reserves, how do we get them to an optometrist, right? So most of these children have never had an eye examination, despite programs such as NIHB that are in place to help them. And so poor vision has a negative psychological and physical impact on the affected individuals. And poor vision can become a negative consequence on society. So IC is a proven working model for bringing eye care to the underserved children in our country. So what we base it on is rather than asking families to travel long distances, IC brings experienced clinical teams to children where they are. And so that leads to the 4 pillars of IC. So the 4 pillars of our program are, the first one is on-site clinics. The second one is the use of telemedicine. The third one is training local youth. And the fourth one is healthcare beyond eye care. So first, to talk a little bit about the on-site clinics in Indigenous communities. As I mentioned, we put together the eye teams. We have all our equipment and we actually go into these communities to provide comprehensive eye examinations for all children in underserved remote areas. And all children that require vision correction are provided with eyeglasses at no cost to the parents, the guardians, or the community. And those that require specialized treatment, like tertiary care, they're brought to the nearest children's hospital within their area. So oftentimes, depending on where they are in Ontario, it might be our head office, which is within the Hamilton Children's Hospital. Next. And then another aspect of our program is actually telemedicine. So this is a way for us to actually connect with the communities when we're not there in person. So we do a number of visits throughout the year, these in-person clinics, but in between, we may do some telemedicine clinics. And so eye care professionals connect remotely with trained local nurses in their community health center to conduct like weekly telemedicine clinics for ongoing eye care. So say we saw a child in person and we said, okay, this child, has amblyopia. We may say, let's start treatment. So we'll say, let's start patching if that's necessary. And then that way we can use telemedicine to actually connect in between. Say we want to do a follow-up in a few weeks or usually within 3 months, right? And discuss the patching process, how it's being done, ensure that they're patching the correct eye. We can also check vision to make sure things are improving. There's a way for us to do it through telemedicine. And that gives us the ability to have that continuous care. So it's an ongoing work to develop these custom-made software, which allows us to actually do these remote eye examinations as well. Next. And so the third pillar that we mentioned was training local community youth and healthcare workers. So this is another aspect where we train within each community somebody like an eye technician for their own community, which actually is something that then they're able to go back to their community and provide things like vision screening. They also can then join, say I was doing like a telemedicine clinic, they can actually join and assist during that clinic as well. And to do this kind of training, we have customized online and modules. So what they do is there's these modules that they watch. They have interactive theory and skills, quizzes. which actually trains them on basic skills of how to check visual acuity, how to do things like using an auto refractor, and how to check like stereopsis, like the depth perception. And then what they do is they are actually brought to the McMaster Children's Hospital in Hamilton for a 1-week hands-on training program. And that's where they're actually brought into the clinic and they get their hands-on experience actually doing those tests. They're able to actually visit other optometry clinics as well and get experience seeing not just children, but also like adults. And it gives them a lot of hands-on skills and experience of different things that might come up and the way that they can actually go back and be successful at doing these tests accurately. We also have ongoing training that happens through modules and telemedicine clinics. So while we're in those telemedicine clinics, I tend to find some time at the end of those clinics to actually have like conversations, make sure that we're staying on top of those skills, and also talk about other things as well. So there's continual training going on. And our first participant in this was actually a high school graduate from Ottawa-Piscat First Nation, which is one of the flying northern communities in Ontario, where she actually came, she graduated high school and we introduced her to maybe a career path in the healthcare industry. She came with her father to Hamilton and we put them up for a week and did this 1-week training program. And it was a great initiative. She went back home and we actually had, now she joins for like the Ottawa-Piscat community for doing telemedicine clinics. And when we go to certain communities that are nearby, she comes and, you know, we bring her over to actually do the in-person training and like skills as part of our in-person visits. So that was one of our first successful candidates for that program. Next. So again, part of our training process, I'll expand a little bit on that, is that we have these didactic learning modules that have like self-directed online modules and quizzes at the end. So they incorporate questions to make sure that their learning is in line with what we're trying to teach. And then they actually have a final evaluation quiz. And there's a minimum score that they need to receive on that quiz to actually then have in-person training. And there is an in-person training process where we have 3 teaching or demonstrating portions that are overseen by eye care specialists. And they help train them on those 3 tasks that I mentioned, like visual acuity, stereopsis, and autorefractor. And that gives them their hands-on experience using this vision screening equipment. From there, they actually demonstrate their skills, and then they enter the last training portion, which is being involved in an OSCE. And so they have to then demonstrate those skills on simulated patients. They're assessed and given feedback before they're actually signed off and said, okay, you're able to go out there and accurately perform vision screening. Next. This is just a little bit of an expert from a paper, Canadian Journal of Ophthalmology, that we recently published in, that talks about assessing the accuracy of non-eye care professionals. So this talks really well about how it's very easy to train someone that's not an eye care professional to be able to do this vision screening, and that's where it's quite successful. Next. Here's another example. This is the one where we talked about that national survey of pediatric vision screening programs across Canada. And this was identifying those gaps in that call to action that I mentioned. Next. And this is one where we put together an evidence-based practice of, how to actually go about doing vision screening. Next. This is the one where we worked with a pediatric specialist putting together, again, the training program that we now are using to make sure that we're accurately training anyone who's doing this vision screening. And then this here touches on our 4th pillar of IC, which is healthcare beyond eye care. So what the aim is here is that we then use the trust that's been established through bringing things like IC projects to these communities, where we then are able to facilitate delivery of other healthcare services. So once we've gone to these communities a few times, we've built these relationships, we've successfully been able to bring eye care to these communities, we're then able to bring in any other healthcare services that are something that they find is a big gap in these communities that they need help with. And the idea is that they join us sometimes on these visits and provide care simultaneously through their own clinics. So for example, we've been establishing wound care clinics that would be given by plastic surgeons. So when we have a trip organized through IC, these plastic surgeons would join us and they'd simultaneously have a clinic to provide wound care, which is something very important within these communities, as you know, through a lot of the diabetic patients that require this. So we're working on that to be able to do that within some of the northern communities that we visit. This here is a slide talking about the different communities that we serve. We've been to 10 different communities in Ontario and 2 communities in Saskatchewan. Of course, when we go to communities outside of Ontario, it means that we put together eye care teams that are licensed to practice within those communities to provide the care. We don't really do that from Ontario, but we are the ones who do all the logistics, because that's the biggest thing with these visits is we are very fortunate to have a number of optometrists that are willing to give their time. Optometrists, ophthalmologists, opticians, they do come together. They understand the need, and so they're willing to join, but there is a lot that goes into these visits, like all the logistics, the planning, the equipment, packing everything, and then also the follow-up when we come back, actually ordering the eyeglasses. So when we're taking care of that through like the head office and the program of IC, we're very fortunate to be able to then visit these communities by other people wanting to join and help give that direct care, because they're just giving up that kind of weekend or those few hours to come and do that. So I'm going to talk a little bit about the impact of IC to date. So to date, we've seen over 1,000 children that have been examined in person. And we found that over 700 pairs of eyeglasses had been prescribed to children, and that over 150 children were examined by telemedicine. And the thing that I find quite surprising is that 74% of children actually needed eyeglasses, and that 49% of the children that we saw had never even had an eye exam. So that means that there's a number of children in these communities, again, almost 50%, had just never had an eye exam. And I still remember to date, the very first time, my very first visit, and seeing a boy who was like 8 years old. And so that would be about grade 3. And when we just started to do vision, he couldn't even see, the big E on the chart, the 2200. And it's just a bit of an eye opener that how are you able to learn anything in class if you were unable to see that? And so that brings us to the fact that only 42% of the children had normal vision, whereas the national average is 72%. And that 51 children were considered legally blind when they weren't given a vision correction. Next. So this is just a breakdown chart of all the children we've seen and the number that had no vision loss based on those standards of in the better seeing eye. How many had mild vision loss, moderate, severe, and some children that were unable to be assessed for that. But of course, we do the full eye examination for everyone. Next. So again, like I mentioned, the biggest eye opener was that a lot of these children just needed eyeglasses. We're not talking about children yet where they needed to be flown in for tertiary eye care. I thought there'd be a number of children who had congenital cataracts and, actually needed surgery. And no, we are really talking about children who just simply needed eyeglasses. So this breaks down what the refractive errors were. And we find that, the amount of astigmatism is quite high. And in fact, it's disproportionately high compared to these urban communities where sometimes in practice, I might see someone who has a prescription of -1, -2 astigmatism. But in these communities, you'd see children that often have -5 astigmatism, which is considered very high. This is also a breakdown of the myopia and hyperopia. So our next steps is that we are engaging more Indigenous communities across Canada, and we are trying to engage provincial and federal governments to increase our funding so that we're able to actually expand the healthcare services across communities that we serve. Next. This here is a map of some of the communities that we're in discussions with. There's 39 communities here in the Anishinaabe Nation, and we were invited, next slide. We were actually invited to a healthcare conference in October last year, where this is where we started those discussions on how we can expand into these communities that also felt like they needed our services. Next. Yep. So this here is from our visit in October when we attended the conference. And you'll see a little picture there of Dr. Sabri giving a presentation. And the next slide is a podcast that he also gave as well. So if you're interested in learning more about the IC, by all means, you can listen to this episode. And here is just a collage of photos from a bunch of our visits. Where you can see some of the children that we gave out examinations to, some of the eye care specialists that join us. There's one there from our telehealth clinics. And this here is a picture of Del Harnish. He was just a big inspiration for the project. He always said that starting something new is a bit of a journey, and a lot of work goes into executing things, such as the program like IC. There's definitely lots of ups and downs, but overall, the ups kind of overweigh it. And that's kind of how this project started as well. I'll be honest, I know Dr. Sabri went through a lot with these communities before we even started our visits. And still, even now, there's lots of challenges. You'd be surprised sometimes. I can even tell you about a visit that I put together. There's a number of visits where I might have put together that we're going to go visit a northern community and suddenly they have a flood and they're evacuating the community. There's one time where we were flying in March and suddenly a storm came out of nowhere, a snowstorm. We had to stop in Quebec and they said that we couldn't even land safely in these communities. So we had no choice but to turn around and go home. And I remember Dr. Sabri and I went and got pizza for our team, and we had quite a large team at that time, 16 people. We joke now that it was the most expensive pizza we ever had because we flew from Hamilton to Quebec for that. But again, it shows some of the challenges that they face in these communities about just accessing that care. Because even to get out and provide a child with an eye exam, you have to fly that child and parent out of the community to receive that care. And it does cost them over $4,000 to do that. They have to put them up overnight and then they fly back. So again, this is just a picture showing like kind of our inspiration for the project. Next. And again, this is sort of the emotional journey that I touched on of creating anything great. That, you start out, you're like, this is the best idea ever. And then as you start, obviously you'll hit your hiccups. There's a little bit of a down low. You think, oh goodness, this isn't going well. And then suddenly, it starts to get a little bit better. And that's where we are now. And we're very proud of the things that we've done with IC, but this is also just kind of that emotional journal that sometimes you go through. And that's everything. So if anyone has any questions, I'd be happy to answer.
Thank you. It's Richard again. It's Richard. Sorry. Thank you. An excellent presentation with a lot of incredible statistics. I can't believe only 42% have normal vision. That's pretty shocking. I'm just curious. I couldn't read any. Obviously, I'm visually impaired. I can't read your statistics on your map, but I just got to the 52%, or the children that needed glasses. Do you have any idea of what percentage has been provided with glasses? I mean, it's, it's such, like you say, there's so many challenges of getting there and getting the equipment and funding and all that. But I'm just curious, I mean, if it's simply giving them a pair of glasses, what kind of percentage or how many children are we accessing and getting them glasses? Thank you.
So I should have made that a little clearer, but during our in-person visits, we actually have an optician that comes along with us. And I specifically put together frames from certain brands like nano, superflex, things that have nice flex hinges that are less likely to break. And we actually take an optician with us as part of our eye care team. And there's a selection of 50 to 60 frames for them to choose. And so every child, if they do require glasses, we ask that they find a frame that kind of suits their prescription, fits well. And we bring all those dispensing orders back to Hamilton. And we actually make the eyeglasses. And then I verify all the prescriptions. And then with help from people like Alexandra, she's a big help in this project, we then put together all the eyeglasses and we send them back to the community. And that way, we're not just going to the community and saying, oh, hey, you do need eyeglasses. Here's a prescription, good luck. We actually take everything with us and we provide a full, complete journey from, starting by screening, having a full comprehensive eye examination. We do a full dilation. We check the posterior pole, the whole back of the eye. And then we do provide glasses if they need it. So that way we're providing glasses to every single child that needs it.
Does anyone have any other questions for Dr. Jindani? I think there's maybe one over here.
Oh, hi. It's David Wood speaking. A fascinating project you're involved with. It sounds a little bit to me like what Orbis Canada does on an international level. Would you ever partner with Orbis?
It's a fantastic question. They are doing amazing things, absolutely. If the opportunity was to arise and it worked and we're still providing things to, all these communities that need it, absolutely.
There we go. I think that's all the questions, Amanda? Yes? So, Dr. Jindani, thank you so much for joining us on short notice. Please give our best regards to Dr. Sabri. So thank you.
Thank you very much. Thanks for having me.
That was very interesting. I found that very engaging myself. So now we will move into our panel discussion. So we'll ask our three panelists to come to the stage, and I believe there's sighted guides coming to help those that need it. While our panelists are coming on up, we have Camelia Zaman. Camelia is a low vision therapist with Vision Loss Rehab Canada. We have Leo Bissonnette. Leo will be representing Braille Literacy Canada and is the third vice president of our CCB board. And we have Richard Mosses, former Vision Loss Rehab Canada therapist and president of Achilles, Ottawa. Thanks, Richard. So welcome to our panelists. Thank you for joining us. So we're going to just start off, and I'm going to give each person about 5 minutes to introduce themselves and to give their firsthand experiences with services across the country. I'll let everybody know that Amanda's going to verbally keep us on track, and she will give each person a 1-minute warning, just to let you know that you're getting close to your 5 to 6 minutes. So let's begin with Camelia. Tell us a bit about yourself and the services. Thank you.
Sure. So, can you guys hear me okay? So my name is Camelia. I am the certified low vision therapist at Vision Loss Rehab Canada from the Ottawa office. In my role, I work directly with individuals living with vision loss, and I help them kind of maintain independence and their confidence and help them participate in society in different ways. through rehabilitation, adaptive strategies, and access to resources and technology. So I work within the community, I work in clinics, I work in the clients' homes, in medical clinics. I can basically work from anywhere as long as I have my little travel kit with me. So the perspective I bring to this panel is very much grounded in like frontline rehabilitation and client-centered care. I see firsthand how vision care affects not only functional ability, but also mental health, employment, education, social connection, and overall quality of life. Another hat I kind of wear as a certified low vision therapist is I'm also an ADP authorizer. So I can authorize funding for devices through the assistive device program after seeing our clients at the office for low vision assessments. So say they're looking for a tool to help with reading, I'd assess their functional vision, we'd figure out what works best for them, and depending on their eligibility, if they meet the requirements to receive funding through the assistive device program, I can authorize that funding, as well as help with training of those devices. Yeah, that's pretty much it for me there.
Okay, thank you very much. Leo, how about you?
Are we on?
Yes.
Well, I'm very pleased. I don't know that it is. Okay. I'm very pleased to be here on this panel. For the next few minutes, I'm going to share the perspective as the director of Braille Literacy Canada. And I note that Braille Literacy Canada was one of the founding organizations, or CCB was one of the founding organizations when Braille Literacy Canada was created. So Braille Literacy Canada is dedicated to promoting and supporting Braille literacy across the country. Our services focus on advocating for the use of Braille as an essential tool for literacy, independence, and access to information for individuals who are blind or visually impaired. We provide a range of services, and I'm going to outline very briefly 5. Number 1, advocacy and awareness. We raise public awareness about the importance of Braille literacy, and we work to influence policies and programs to ensure accessible education and resources for Braille users. Our second broad area is training and education. We offer training and professional development for educators, families, and professionals to enhance their skills in teaching and supporting Braille literacy among users who are visually impaired. And indeed, I would note that we certainly benefit with our collaboration across the country with various organizations. The third area is resource development. We develop and distribute educational materials, tools, and resources in Braille to support learners and educators and rehabilitation specialists. Our fourth area is community support. We foster a community of Braille users, educators, and advocates by hosting various events, and we certainly benefit by using Zoom for this. And we hold meetings often in this area. The fifth area is research and collaboration, and this is key. We collaborate with various stakeholders to promote research and best practices in Braille literacy. Overall, Braille Literacy Canada works to ensure that people who are blind or visually impaired have, and I stress this, equal access to education, information, and opportunities through empowerment for the use of Braille. Now, the key point in my presentation is coming up now when we talk about Braille Industry Canada's Braille Zoomers program. This is where we get a chance to work with users who are suffering vision loss. This is a monthly virtual support group designed by and for adults and older adults in Canada who are learning Braille, especially those who start learning Braille later in life. The meetings are informal and supportive, focusing on sharing resources, tips, and ideas among participants. And I will say that sharing among participants suddenly makes people say, my God, what I do is valuable to others, and I'm teaching. That's key. The handouts and resources and strategies discussed in these meetings are provided to all participants and those who subscribe to our listserv. And I'd stress that there's no cost or obligation to attend these monthly meetings, although I will tell you that the attendance certainly is very steady. People really feel empowered. Now, for the time remaining, because I do come from Quebec, I wanted to make a couple of comments about the different service levels in Quebec that maybe make it stand out a little different from what you have. Vision loss rehab certainly does a great job across the country, but sadly they don't have a place in Quebec in their system. I would note historically that in 1975, the Girard Commission created the first delivery models, which stressed that there had to be training, not just handing out an aid or device, but there had to be training and an appropriate evaluation. That's been important and still continues. So what we have in Quebec right now are regional centers in major cities. For example, in Montreal, the Montreal Association for the Blind, now known as Lethbridge, Leighton, Mackay, in Montreal provides services primarily to the Anglophone English-speaking population. Institut Nazareth Louis Braille pretty much takes care of the French-speaking population. There are service centers in Quebec City and Sherbrooke as examples. Now, the real question is what happens in the other outlying areas. Clearly, there are gaps. Postal codes don't necessarily help, and the needs. So with that, I end my presentation. Glad to take questions. And I think we may have, for Braille Literacy Canada, some Braille markers to hand out with information, but at the end of the formal presentation, as the panel completes, I'll give information about how to contact Braille Literacy Canada. Thank you.
Thank you, Leo. And Richard, tell us about yourself and the services.
Hello?
You're good.
Okay. First, before I start my presentation, I know earlier I made a very strong comment about emotional support animals. I just want to clarify, I believe they have a valid place, and I'm not putting them down or saying that they don't serve a good purpose. Unfortunately, like many things, people take advantage of certain programs and make it sort of, you know, they destroy the good parts of things, as we see with AI and the internet and everything else. So please, I didn't mean to offend anybody. I think there is a valid place for emotional support animals. Thank you. Okay, my name is Richard Marsley. I am the president of Killy's International Ottawa. And the international is because our head office is out of New York City, where they have, I don't know, something like 500 athletes that are blind, visually impaired, amputees, and in wheelchair. We have something like 60-some chapters all around the world. Here in Ottawa, we mainly have persons who are blind or partially sighted, simply because we don't have the resources to deal with the other disabilities. So I'm coming at this from a lens of sports, leisure, and recreation. My vision, my dream one day is, like every other sighted person, I can just walk into a community center and take aerobics, yoga, dance, play adaptive tennis, whatever sport that I want to at any other community center, I can just walk in and it'll be available to me. I won't have to break down every barrier and be told, sorry, you can't be in this class because you're a liability, which I've been told many times when I've tried to take aerobics classes or something. So that's my dream. One day, I hope I live long enough to see that dream come true. But there's so many inequities in the services provided. I'm fortunate that in Ottawa, we have quite a few people who are leaders in starting things. We've had Ski Hawks, which is the downhill ski group. They've been in service for over, I think, 35 years. It's phenomenal. We have CADS, which deals with all disabilities. We have the Blind Curling Club. We had blind bowling. I'm not sure if they existed because most of the bowling alleys have closed, which is unfortunate. Skiing, and we have our running group. And so we are fortunate here, and I'm in the midst of trying to start a sailing club for the blind and visually impaired with the assistance of Blind Sailing Canada. And I'm hoping one day, if I can split myself into more parts, we will get adaptive tennis in Ottawa as well. But if any of you are out there and you'd like to participate and take on the leadership role, I'd really be happy. And many studies, just like our previous speakers, many studies have shown that through sports that it can really impact our mental health. Achilles International out of New York has done many, many surveys and questionnaires with its participants, and all of them have said how it's increased their self-confidence, their self-worth, their mental health, their overall health. And for all of you people who are looking for the fountain of youth, they've announced recently, if you exercise, there you go. It'll create new neurons and keep you young. So let's all get out there and stay young. But yeah, so again, you know, in Ottawa, I'm fairly lucky. But at the same time, if I want to play adaptive tennis, I got to go to Toronto. Not exactly an easy jaunt to do, you know, just 4 or 5 hours away. And if you're out in the rural areas, it's even worse. I grew up in Cornwall, and that's about an hour east of here. I left at 30, and I never heard of one adaptive sports for blind or visually impaired. Not even goalball, which was designed in 1942 for veterans coming back from back from war. That's the only sport that was designed for the blind and partially sighted. So there's many gaps. So all across Canada, you will see like Vancouver, Toronto, Ottawa, and a few other communities that have some sports. But in most rural areas, they don't have any. So for people who are high energy or just want to be involved in leisure, like crafts, whatever, you know, walking groups, anything out there, it's very difficult, and it can really make us isolated. And that's one of the biggest challenges with persons who are blind or visually impaired, is we become more and more isolated when we don't have the services. So you can see that all of these different things that we've talked about today, they all overlap, because you need the transportation to get to these things. You need the economics, or you need the funds so you can participate to buy running shoes to that. And part of Achilles Ottawa, we've been working with different organizations, and like Run Ottawa, that's our big event, they were able to fund some of our athletes to buy new running shoes, to pay for their registrations. And that's what as Achilles Ottawa, as we gather our funds, that's what we're trying to do as well. So in Canada, we just have our main office in Toronto. We have our one in Ottawa, and we have one in London. So you can see there's a definitely inequity in getting things out there. And the one thing, you know, we just got to get the word out there to show how much persons with disabilities can do. And I think that's our problem, is attitudes, still 90% of the issue. So I'll stop there.
Richard, 1 minute.
What?
I stopped.
Perfect timing, Richard, perfect. I was just about to say, nobody needed a warning, so we were really good there. So I have a couple questions for each of our panelists, and then afterwards, we're going to open up some questions to the floor. So get your pens and papers ready and jot down any questions that you think of while our panelists are answering the next two questions. I'd like to start with Leo. Can you walk us through what it looks like for a person, client, or a patient navigating your system or accessing your services?
Well, in terms...
You're on. Sorry, yeah.
In terms of Braille Literacy Canada, all you need to do is connect with us and we'll begin, and again, the Braille Zoomers is perhaps one of the best examples where if you're looking for suddenly having to deal with the possibility of learning Braille, and it doesn't mean learning every aspect of Braille, you don't have to learn contracted Braille, but maybe all you want is enough to label a pill bottle, get in touch with us, and we take you through a process. Again, when I described the Braille Zoomers program, I indicated that the program has been designed by and for persons with vision loss who are using Braille. So there's that peer support, and it's very supportive. And I think it works both ways. For those who come to the program and get their feet wet, they're working with participants who, like themselves, have come to use Braille later in life or at some point in adult life, and say, hey, I'm here, I've been down that road, and I can help you, and we mentor each other, and we move forward.
Thanks, Leo. So Camelia, did I say that right? Thank you. So walk us through what it's like for a patient navigating Vision Loss Rehab Canada.
Yeah, so over the years, VLRC has definitely simplified our referral process. We have 3 methods of referrals. The most classic one is getting a referral from an eye care professional, like an optometrist or an ophthalmologist. We also receive referrals from healthcare professionals, such as occupational therapists, physical therapists, nurses, social workers. And then we also have the third option, which is the self and community referrals. So this is a unique option because it allows our clients to just go on our website or give us a call at our call center to refer themselves for our services without any formal visual diagnoses or eye report information. Our services are covered by OHIP, so it's pretty easy to, receive referrals and for clients to see us for assessments. And if eye report information or information about their visual diagnoses are needed, we can request it after the vision assessment, the low vision assessment, so that way we have, we're able to reduce our wait times and just see the clients as soon as possible within our offices. So, yeah, that is the referral process for VLRC.
Thank you. And Richard, what does it look like for you at Achilles?
So for people who want to join Achilles Ottawa, it's pretty straightforward. We're a small grassroots club, and either through our Achilles Ottawa website, or a lot of times if a person who has a disability or blind or visually impaired, a lot of times they see us out in action on the canal with our bright yellow shirts. So a lot of times our clients see us there. They might see us through our Facebook page or any other social media part, or a lot of it's just word of mouth. So they contact us, we return their email or phone call, we have them come to we're out of the CNAB. They've been very kind to the CNAB hub to let us use their space every Sunday. So basically people can drop by there. We welcome people as easy as they possibly, we make it as easy as possible. We want everybody to get to the starting line and to be involved and get off their couches. So as easy as we can make it, we will. And when the clients or athletes, as we call them, when they show up, we introduce them to our program. We tell them about the communication part of it, like using tethers, how you work with a guide, explaining to your guide what you need, if they need any other training, and we tell them about, that we're here to support them in any way we can, to help them with funding to get to races, if they need equipment. So we try to educate them as much as we can on what we can provide them and how exciting it is not to just run or walk, but the social part of it, because that's how they learn about different resources in the community, how others adapt to their vision loss, and just how much it's fun and how much they can gain out of being involved in sports.
Thank you. Yeah, I kind of have to agree with you. I love to participate in social sports where there's a group. If you ask me to go work out somewhere, forget it.
Well,
I have no interest in just working out, but curling, yes.
Although we do
Curling and
match it
bowling.
with food, so for a lot of us, we do sports only because of the food.
Yes, exactly. Oh, there we go. Yeah, I think every chapter knows you bring in food, you bring in members. It's true. So the next question, we'll reverse. We're going to start with you, Richard, on this question, and we'll come across this way. So what national or regional policy or funding change would make the biggest impact on your work and or the population you serve?
Wow. I've been thinking about that, and there's so many ways to go. But I think for me, I would like to see more collaborative funding, just collaborative work together through the different levels of government, the different levels of community involvement in sports and leisure. Because as I said, it affects every part of my being, my overall well-being. And we never much talk about perceived vision loss or perceived function vision. We might have 20/50, but is that what I really see? Because of my emotions, my physical well-being, I might perceive my vision as something more dramatic or more extreme. So it's so important. And oh my goodness, I just went blank. Can you restate the question? Oh
Yes,
my God.
yeah. No,
I'm having a senior's moment.
that's okay. National or regional policy or funding.
Yeah. So I think, as I was with my problem, I've been the president for 5 years of Achilles, and we always run up against the same problem. We're not a charity, we don't have charitable status. So I've read hundreds and hundreds of websites, and so has my board members. Unless you have charitable status, good luck. You can't get funding. So that's been my biggest frustration, that until you can get your charitable status, you're basically stuck doing fundraising. And so I've been very blessed by telling my story. As we all know, it's sharing your lived experience that can really help you. So for me, because I've been out there, I've done, Ironman or half Ironman, and I've done triathlons, I've done many marathons around the world. So people know my story. And through that, I've had friends and that who have made quite a few donations to us, to Achilles Ottawa. And we've had our guides that have done ultra marathons and have set GoFundMe pages to help us. And again, through that, we can help people get to the starting line and pay for equipment and the treats that we have for our socials and everything. So I would really like governments and community organizations to all work together to look at, when you always hear people talking about grassroots. Well, what does that mean? Do you have to be a full-fledged club that has A, B, C, and D? Or can you be a basic startup club like us that doesn't have to have our charitable status, but can still, by proving, through stats or through our numbers, through what we do, that we are a valid organization and that we are making a difference, but that we don't have to, jump through all kinds of hoops. But thankfully, Achilles International Canada and they have been, I think it's been about 3 years, they've been working on their charitable status, and we're hopefully getting an answer in July. But then from there, we have to hope that London and Ottawa can fall under them and they can write tax receipts for us. But you know, sports is so important for children. Like we don't even see it in schools. In my 30 years as a rehab teacher at Vision Loss Canada and CNIB, I've heard so many times where children have had to sit on the sidelines because schools won't adapt. They won't get balls with bells, frisbees with bells. They won't get different equipment that could easily integrate our children. You know, it's so frustrating that something so simple seems to need so much willpower and so much tearing down barriers, you know? Like I said, it would be my dream that one day we can all just walk in and at the schools, when kids arrive at school, they can play all sports that are adapted in one way or the other, or I can walk into a community center and I can take an adaptive program, or just take a regular class, but the teacher knows how to say left, right, forward, backwards, you know, whatever, knows basic language. Thank you.
Thank you, Richard. So, Camelia, so I'll just give you the question again. So what national or regional policy or funding change would make the biggest impact on your work for your population that you serve?
Yeah, so I just want to start off with explaining the equity barriers that I face in my work. The biggest equity barrier, I would say, is unequal access to vision rehabilitation services and assistive technology. And 3 kind of regional policy or funding changes I would like to see are, first of all, increasing funding to better cover cost of travel. Specifically in northern regions where there is virtually no road access, we have many fly-in communities. We're traveling, 8 hours a day just to get to these locations. A possible solution would be to open the Northern Ontario travel grants to include VLRC services. So currently the Ministry of Health provides this grant to cover mileage for only certain medical professionals. By opening the grant up to vision rehab, we reduce wait times, which is very important. The second kind of policy change I would like to see is, some kind of investment in infrastructure that will provide virtual services in remote communities. Because if we can't travel to these communities in person, we might as well have some virtual services in place. However, some of these remote communities, they do not have the connectivity options to provide the virtual services. So what we can do is we can connect with different Indigenous health centers. We can get them set up with internet, high-speed internet, and provide them with the necessary equipment so that we can provide virtual services, again, reducing our wait times. And the third point I'd like to make is increasing equipment supports to have our offices better established without the financial hardship on our organization. Currently, the assistive device program, they recognizes 4 of our offices plus 1 satellite clinic in all of Ontario as regional assessment centers. Again, because we only have these 4.5 centers, it does increase our wait times. So we have longer wait times. The solution to this, I would say, is to recognize more of our offices as regional assessment centers and increase the necessary equipment supports in those offices, again, reducing our wait times. So, thank you.
Thank you very much. And Leo, would you like the question again, or are you okay?
No, I'm good.
Good.
I just have to make sure that this microphone, is it on?
You're good.
Okay.
Yeah.
Well, one of the things, I talked earlier about resource development when I was outlining the various services that we offer. And I think the extension of that has been in recent years where we have developed a Brailler Bounce program. And what does that mean? Well, it means getting braillers that people have donated back to us because maybe a family member no longer needs them. What we've been able to do is service these, refurbish them, make them usable. And then we have developed a program where people can apply and are evaluated for whether this would be an appropriate tool for them to have. So that's a very important extension of putting Braille back in the hands of users. I think what's going to be also very important to see, and we see it with the emerging of a new generation of technologies, Braille technologies, what can we get in the hands of our users? Maybe we want to have a number of items that people can take to conventions and trips and so forth across the country, so people can get a sense of what could be in store for them with this new generation of emerging technologies. So it's an exciting time. Thank you.
Thank you. So we can open up some questions to the floor as well as any questions online. I think Amanda or Braden will have the mic. If anybody has any questions for any of our panelists, please put your hand up.
One question over here.
Okay.
Thanks. This question is for Leo. Leo, I'm 5'3", tan-colored, brown hair, dark brown hair, glasses, red wine-colored blazer, black shirt, black pants. So my question for you is, so I'm Nina Huja, I'm an ophthalmologist. I was curious about your Braille Zoomers program and how far along the path of vision loss are people who are coming to you at that stage? And do you think that there's a place for patients who, say, have a condition that will progress to extreme central vision loss in the case of macular degeneration or glaucoma or whatever that condition is? Do you think there's room or capacity or benefit to people joining those programs before they've hit the stage of severe vision loss?
Absolutely. You know, really, any moment is a good time. And I think for adults who have maybe resisted that because maybe they've been sold, well, Braille's not for you. Frankly, what Braille Literacy Canada says is Braille is for every person with a vision loss, because maybe at some point their situation will change. So the door is open. If people wish to experience Braille, try it, come. Our website is brailleliteracycanada.ca. You are more than welcome to participate in our Braille Zoomers program. You'll find great mentors, and you'll find support for your clients.
Thank you.
Just one more question over here.
Hi, my name is Anne. This question is for Leo. I work with Vision Loss Rehabilitation Canada here at the Ottawa office. And I just had a couple of questions about your refurbished, I presume, Perkin Brailler. What sort of system do you have for repairing them? Who's repairing them now? We used to have someone in Cornwall doing repairs, but that kind of has gone by the wayside. And how does one qualify or be eligible for one of those Brailler donations? Thank you.
Okay. Several points to make. Number one, I wish Daphne Hitchcock, our president of Braille Literacy, was here. Basically, Daphne works very closely with people in BC at the present time to help repair the Braillers that we get. And what happens is that once they're refurbished, we have a list of people who have qualified, if you will, for the distribution of a receipt of a refurbished Brailler. But long-term, we need to find people in Canada who we can get trained to repair these Braillers. That is an outstanding need that we have. It's certainly been discussed at the board level of Braille Literacy Canada. We are acutely aware of the concern and the need.
Hi, this is Vanessa from Vision Loss Rehab. I work specifically with reinforcement of skills, And I've came across a few situations where my clients wanted to go back to school, post-secondary, and they were told that they cannot attend these programs because there was no way for them to have the literacy, so the books made out of Braille or audios. So I'm wondering if it would be through your company that we could connect and see if there's potential to make the books, or if there's somebody else, if it's the colleges or the universities that are in charge of that.
Can I take the question now? I'm a retired professional who set up an office for students with disabilities at Concordia University in Montreal. I set that up 35 years ago. And the purpose of that office was to service all disabilities. In terms of the specific needs of those for Braille, we contracted in Quebec, for example, with Jacques Côté and his company. I'm not sure if they're still around, but we had to find the companies that would produce the Braille. We also had to, in some cases, train students who were, taking statistics courses and how to use Braille to read mathematics. Jacques Côté and his people at the time did provide us with that, and that's essential to this. But I think to say that someone can't go to school because they don't have literacy, I think you've got to build it for them in stages. It's not easy, but I think the universities now, for the most part, have offices, certainly in the main universities, that are acutely aware of the need to support those who need Braille. And again, I'll go back to a point I made about technology. There's great interest now for Braille Literacy Canada in looking at the next generation of multi-line Braille displays to see how that will impact on some of the disciplines like mathematics and science and Braille music, for example. So it's an interesting time. I think there's a lot of good things that are moving forward, but indeed, get your students connected, get your clients connected with the universities in your area. They're not all equal, but they're certainly out there.
Please do, yes.
So I'll cover not just Braille, but as Leo was saying, the universities, colleges, and other programs do have special needs departments. However, and they do their best with the resources they have, but you need to advise people they got to start 6 months before at least.
That's right.
Because when I was doing university, and yes, I'm old, but not that old, I would take my books to get them scanned. I would get the first chapter a month or two after the course started. So you could see I was quite quickly left behind, or had a lot of work to do in the last few weeks of the class before exams or whatever. So you must, and as I've always told my students, you need to get there. You gotta self-advocate quickly, be on top of it, because they do provide the resources. But again, depending on each university, it depends on how many people they have doing it, what their financial resources are. You always got to go way in advance, because a lot of times the students have to buy their own books. They bring them to the special needs department, they cut them up, they scan them, and they do it. Some universities, I have to say, are getting better. Some programs are putting all their materials online, so the students can access their materials online, which is fantastic. I hope that's the way the future is going. There's more private, like if they're going to a private college, like Heritage College or others, or if there's students that are going back to get high school credits, like adult education, it is really difficult. I've tried working with 3 or 4 schools, and unless you have one person who's really pushing for that, they're kind of stuck. This is what we have. That's all we can do. We can't make things large print. We can't get Braille. So it's very, very difficult. But the colleges and universities, the expectations, they will be there. Or sometimes you have to get a reader. So if you can get some grants or funding through OSAP, you can get funding and put it towards special equipment, or to hire a reader that will go to like take notes and stuff like that. Hope that helps.
Hi, this is Diane Bergeron from CNIB. My question is for Richard. Don't panic, Richard. I'm already sensing the fear on your face, but we're good. I'm thinking about pre-2020, when we had a very active group of triathletes in this town, where there was a lot of runners and cyclists, and then COVID hit, and suddenly we couldn't be out with our guides unless they were family members or within our circle of, 6 people or something. And it was very difficult. And here we are 6 years later. And during that time, I'm sure there's other folks like myself who haven't gotten back into it for various reasons. But I'm thinking about Achilles in Ottawa and thinking about the program that you were talking about, meeting every Sunday. What kind of support does the group provide to first-time runners or those folks like myself who are going, oh, darn, I should have done that, but, having to get back into it from, the couch potato? How do you help us couch potatoes?
Just to clarify, Diane and I have been great friends together. We've done half Ironman together, and we're just crazy, passionate athletes. So that's where that's coming from. I'm never sure what Diane's going to ask. But, that's the beauty. When I first started with Achilles, and before I was president, we were mostly runners and joggers, whatever. Or as we like to say, yoggers, that's half running, half walking. I'd say half of our group now is walkers and runners. So we just welcome everybody. We take it slowly. We try to educate people to, just take it slowly. If you can only walk 15 minutes, that's fine. If your goal is to run 5K eventually or walk 5K, let's start off with 100 meters, whatever it takes. Make sure you got the right equipment. Tell them, all the benefits of running or walking. And then we connect them with our guides. We have a training program for guides on how to communicate, how to guide, not just when you're out running outside, but how do you get from the table to the door? How do you get from the table to the washroom? How do you, describe things? Each person is different, what you need. So we make sure that they're well trained on how do you use different types of tethers, different types of vision, what people see, central vision, peripheral vision. Some people want to have everything described. Some people want very little described. Some people want a countdown, 1, 2, 3, step up. Others like me is like, no, don't do that, please. Just say yes now. So we try to bring everybody in. We introduce them to all the other athletes, show them like other walkers, other runners, just try to tell them all the benefits of the program, make them feel welcome. One of the most important things I've tried to do in the last 5 years is say, this is a safe, welcoming environment. Everybody's welcome. I want everybody to feel comfortable, feel safe, know that you're valued and that we all are here for the same goals. And that's how we try to encourage people to come back. And, in the last several years, we've had people who have been through strokes, through car accidents, and could barely move for at least 2 years. They've worked their way back, and now they're entered into the 5K walking part of the Ottawa Race Weekend. So we've been with everybody. It's all about providing good support, good guides, letting them know how valued they are and how much they can benefit from it.
Hi, I'm Joanne. I just want to make a quick comment because I got to leave. I was a marathon runner until 2020. I won bronze in the women's vision impaired category. I have also won first place as well in that same category in 2020. I retired because of health reasons. But my comment is, I just want you all to know, I am the first blind person to go to my community health center and take a cooking class. I am the first vision impaired lady to do a cooking class. I do it twice a month on Fridays. I teach the instructor as much as I teach myself on what I can and what I cannot do. And just this past year, I'm also the first vision impaired woman to play darts, to actually play darts at the Montgomery Legion here in Ottawa on Kent Street. I play on Wednesday nights. So in my opinion, vision doesn't matter. Whatever you can do in life, with vision, without vision, that's all that matters. So I just wanted to make that comment.
That's Joanne, by the way. I'll hook you up later, Richard.
Exactly. And Camelia, we have one question online here for you, and that was, as a certified low vision therapist, I hope I got that right, what is one thing you wish people knew about your profession?
Yeah, I wish people understood the range of visual impairments and sight loss, and that just because you're visually impaired doesn't mean that you see nothing at all. I have had a lot of family members ask me exactly what my profession consists of. So I'm very used to explaining what I do, how I work with people with sight loss. I work with them to figure out how they can use the remaining functional vision to do their daily tasks. Sorry, can you repeat the question one more time?
Oh, you make me feel so much
Sorry. Yeah.
You've begun to answer it perfectly, but the question was just, what's one thing you wish people or the public knew about your profession specifically?
Oh, yeah, so that's basically it then. That, what I do is that I work with people with various degrees of vision loss. And it's very important that people recognize that just because you see someone walking with a white cane doesn't mean that they have absolutely no vision at all. And vice versa. Maybe they don't have any vision at all. You never know. But yeah, it's just awareness of low vision in general, I would say, is what's important.
And that's it for the open questions. So I'll hand it back to you, Leslie, for the final question.
Thank you, Amanda. So I have one more question for each of our panelists. So the question is, what gives you hope about the future of rehabilitation and vision services in Canada? And this time we will start with Leo and work our way across, okay?
Years ago, I had the opportunity, going back to, oh my goodness, the early 80s. Some of you will remember the emergence of the VersaBraille technology, old technology. I was hired by the Montreal Association School for the Blind to teach it. And that began my understanding of what rehabilitation and support would mean. And again, over the years, because in the work that I did at the university, I had the opportunity regularly to meet with colleagues who were doing the kind of work we talk about here. And I'm very optimistic about what they bring to the table from the vision loss rehab perspective. And I think the professionals there continue to keep pace with what is emerging. I think there's a greater understanding of what the technologies are that are emerging. And I think there's a real sense of the need and the wish to empower the clients that we all serve in our various roles. So I guess I'm an optimist. I look forward. I guess funding obviously is a big issue. What can you get? But I think there's so much being done in the regional levels. Now, if we can filter up to the policymakers and maybe some kind of a long-term Canada-wide program that equalizes things, that's way in the future, but I'm an optimist. Thank you.
Thanks, Leo. And Camelia, what gives you hope about the future of rehabilitation and vision in Canada?
Yeah, so I would love to see the access to vision rehab services increase, as mentioned before, in remote communities especially. We've definitely already made strides with that with the Bill C-284. We also have different programs within Vision Loss Rehab Canada to, promote that, such as one program we have is called the Eye Health Screening Initiative, which is an initiative where we have our specialists use fundus cameras to screen for diabetic retinopathy in remote communities. So we have a lot of different programs like that going on. And I also would love to see the evolution of technology to integrate AI into, optical aids for our clients. I think that would be a huge benefit for them for sure. But yeah, definitely increased access to vision rehab services in remote communities and the evolution of technology, I guess.
Thank you. And Richard?
Okay. Wow. I guess being an internal optimist, I just see so much hope. Just listening to all the different speakers today, hearing, when I started in 1994 at CNIB, a lot of the organizations like CNIB, CCB, not so much worked together. It was more like World War whatever, AEBC. It wasn't a good thing. Now, seeing like Jennifer Eurosvik speaking about the oh Lord, I just forgot again, the health collaboration. Sorry, Jen, short-term memory. The fact that all the listing of all the organizations that she listed that are all working collaboratively together, oh my God, I'm over the moon. It's taken a lot of years to get there, but they're getting there. And yeah, as Jen mentioned, there are some challenges, amongst different organizations. Each organization has their own missions, their own views, their own goals, but to try to think outside the box and all work together for better vision health is phenomenal. And I think Dr. Scott made my day today by mentioning Skate Canada has a program on accessibility, and they're looking at that. I know I have an athlete in my Achilles Ottawa. She is totally blind and does figure skating. I mean, it helps that her mom is with Skate Canada. But she does every sport you can think of, and it's phenomenal. And I'm hearing more and more stuff like that. I have a friend she's totally blind, and she's doing horse jumping, water skiing, like adaptive tennis, sailing. There's so many sports out there. And just seeing, even with via rail. So, accessibility to all kinds of things, to vision loss, to vision treatment, to travel, to sports, to leisure, all the stuff that, like in Ottawa, I see the CNIB hub. If anybody knows Becky Dick, who's a youth and adult worker, oh my gosh, she does so many phenomenal programs. I've never seen so many children involved. Over the years, it wasn't quite like that. We worked our buns off to bring programs, but they didn't show up, and now they're showing up. She's doing phenomenal stuff. So there is so much great work, and listening to Joanne, it takes each and every one of us, not each group, but each and every one of us persons who are blind or vision impaired to advocate, and I see so much of it. So many young people, saying, no, this is what I want. This is what I require. These are my rights. And it's awesome. I just see there's so much hope. We've come so far. We have a long way to go. But man, living in Canada, we have so many more opportunities than so many other countries. I say to all of you, thank you, thank you, thank you. Keep up the great work. And man, to be blind or visually impaired, we can have a great quality of life if we choose. So there is so much we can do and so much hope. Thank you.
So thank you very much to our panelists. It's been wonderful listening to you guys share your stories and share the experiences. So looking at the time, I think I'm going to give everybody probably about 15 minutes back of their day today. So like I said, please don't just run off. It's an opportunity to network, take pictures, and say hi to those folks that sometimes we only ever see on Zoom. So please stay for a little bit afterwards. So as we wrap up today's portion of the conference, I want to take a moment to reflect on what we've heard and the conversations that we've begun. Today truly embodied our theme, Pan-Canadian Voices, a national conversation in the future of eye care in Canada. Throughout the day, the voices came through with clarity, honesty, and purpose. We began with Angelica Hanna, who showed us how socioeconomic factors shape access to eye care long before someone reaches a clinic. Her research reminded us that inequity is not random, it follows patterns tied to income, geography, transportation, and social conditions. If we want different outcomes, we must be willing to change the systems that produce them. Then we heard from Dr. Alison Scott, who brought both a national and East Coast perspective to the realities of delivering optometric care. She highlighted the complexity of Canada's patchwork of funding models, workforce shortages, regional differences, and the importance of collaboration across professions and provinces if we want a system that works for everyone. We then welcomed Jennifer Urosevich, representing the Vision Health Partners Coalition. Her update on the National Strategy for Eye Care Act underscored the momentum building nationally and the need for continued advocacy to ensure that this strategy becomes real, actionable, and changed. Catherine Langlois from Via Rail reminded us that accessibility reaches far beyond healthcare. Inclusive travel is essential for everyone. She outlined Via Rail Canada's current accessibility plan and highlighted key initiatives designed to make travel across the country more inclusive and barrier-free. After all, accessible travel isn't a luxury. It's a vital part of our overall health and well-being. We were going to hear from Dr. Sabri today, but Dr. Janine did a wonderful update on the Indigenous work that they're doing. Their work with the ICEE project is a powerful example of what culturally grounded, community-driven care can achieve. Her stories highlighted both the challenges and the profound impact of meeting children and families where they are. This afternoon, our panel on rehabilitation and services across the country brought together three remarkable leaders, Camelia, Leo, and Richard. They spoke candidly about regional disparities, gaps in service delivery, and the disconnect between what people need and what systems currently provide. They also reminded us that rehabilitation is not just about skills or devices, it is also about dignity, independence, and the right to fully participate in community life. And as we ended the panel, each speaker shared that what gives them hope. That theme of hope is what I want to leave you with all today. Hope for equitable access to eye care and rehabilitation in every region of the country. Hope for systems that reflect the realities of the people that they are meant to serve. Hope for collaboration that bridges professions, provinces, and lived experiences. Hope for meaningful action on the National Strategy for Eye Care so that no one is left behind. And above all, hope for a future where vision loss is not met with barriers, but with timely, person-centered, community-rooted support. Because despite the challenges we heard, and we did hear challenges today, today was filled with examples of innovation, leadership, and commitment. We saw what is possible when researchers, clinicians, policymakers, accessibility leaders, and people with lived experience come together with a shared purpose. Today showed us that the future of eye care in Canada will not be shaped by one sector or one region. It will be shaped by all of us, by the voices in this room, by the communities we represent, and by the collective belief that every person in Canada deserves equitable, accessible, community-rooted vision care. Thank you to each of our speakers for your insight and your honesty. Thank you to all of you for your engagement, your questions, and your dedication to this work. So as we close, let's carry forward the momentum, the ideas, and the hope we've built together, and let's continue this important national conversation in the days to come. So as a final thank you, I would just like to recognize Amanda, Braden, Mohammed, and the CCB staff for their hard work in organizing this conference. Thank you. And thank you to all of our sponsors and supporters. Thank you everyone for attending, and thank you for all those who have joined us online. So please enjoy a free 15 minutes. And let's take some pictures and do some networking. So thank you all for coming. It's been wonderful. Thank you.